Okay, good morning. Can you guys hear my voice? How is everyone doing? Can everyone hear my voice? Can you guys hear my voice? Okay, good. Okay, so welcome to the 30th lecture of Dr. Heidi's Step 1. We have come a very long way from starting first aid 1 month ago, and we have finished some of the most biggest monster topics of USMLE Step 1. Good morning. Hope everyone is feeling good. Thank you for attending the lectures and welcome to the last lecture of this week. Okay, today we are trying to keep this as fun as possible. The reason being is because we want to start our neuropharmacology, and it's a pretty difficult, at the same time, it's easier than the previous pathology topics that we have been discussing for the last many days. Having said that, there are things about neuropharmacology which is extremely easy. Okay, and we will tell you exactly how you can address it, and you can knock out all the questions that you can get from the neuropharmacology. And there is a certain way how a student should address the drugs in the CNS. Okay, and we will try our best to teach you exactly how that's going to go. And once you understand that, you will realize that most of the pharmacology portions in CNS is extremely easy. And once again, this will allow you to answer all your questions in UWorld and in the actual exam with absolute confidence. Okay, having said that, before we wait for 2 to 3 more minutes for everyone else to join, I would love to know how many questions did you guys solve in your UWorld? Okay, I would love to hear about everyone's particular question solvings from last night or yesterday or today morning, depending on which time you guys are doing our classes. Okay, 40, good. 30, okay, very good. Anyone else? 35, okay, that is very good. Are you guys solving questions system according to the systems? Okay, good. So if you guys are solving questions according to systems, then you guys are doing neurology right now, if I'm not correct, right? Or are you guys doing questions from previous topics? Okay, so we always get okay, good. Neurology, very good. Since you guys are doing questions from neurology, are you guys finding questions easy after doing the lecture, or do you still find it difficult? Or do you still find it difficult? Okay, okay, good. The thing is, questions from neurology usually should not feel easy. Okay, but I'm glad that you guys feel that way. That's exactly what happens after you read first aid text by text and you understand each and every concept. So if anyone feels easy while doing the question, that's absolutely good news for them, and that's a wonderful news for us too. That means both of us have succeeded. We have succeeded in teaching you guys, and you have succeeded in learning the neurology. So, congratulations. Okay. So, do we have any complications or questions regarding USMLE before we begin our lecture so that we can get it out of the way? Any questions regarding anything? Okay. Okay. So, the thing is, we have received a lot of emails. Okay, there's one thing I would like to talk about before I receive questions. We have received a lot of emails regarding lectures of regarding lecture number 3, lecture number 5, and lecture 6, and all the previous early lectures. Okay, so the problem is while we were trying to edit our videos, okay, some of our lectures did not come out as wonderful as we would have wanted it to. Okay, so we decided to not put them out because what this would do is instead of teaching you guys, those lectures would end up confusing you. Okay, so what we decided was instead of providing those lectures for you, we would we would love to take lectures again. Okay, this is for the old students. This is not for the new students, because for the new students we would like to take the classes they have missed once again. Okay, that's not the problem. But for the old students who has done the previous topics, for example, CVS, endocrine, and all those topics, for those students, if you guys have any confusion, yes, if you guys have any confusion regarding the previous topics, if you can mark out the topics that you want to talk about or that you want to discuss, okay, we would love to take lectures regarding those topics once again. Okay, we would love to take lectures regarding those topics once again, but we would be taking those lectures after the end of our regular topics. Okay, so let's say we target cardiovascular system. Okay, let's say we target cardiovascular system. We can repeat the cardiovascular system once again. Okay, we can repeat it once again. That's not the problem. But either we can do the whole thing, or we can do some of the important topics where you find difficulty in, and we can only repeat those topics. Okay, but if everyone finds difficulty in cardiovascular system, for example, and we have to repeat the whole topic once again, we can also do that. In that case, what we would do is we would also let our new students know that we are repeating cardiovascular system, and that way they can get done with the cardiovascular lectures too. Okay. So having said that, we apologize for the videos not being proper. So we did not send them out, but at the same time, we would take the lectures once again. So hope that helps. Okay. Do you guys think that would be a good idea? Instead of watching the previous videos, does that include lecture number 25? No, it does not include lecture number 25. As a matter of fact, give me 1 second, please. What I would do is, since you have asked for lecture number 25 instead of, okay, 1 second, lecture 25. Okay, so we still have, we have all the lectures from lecture number 13, 14 onwards up to now. Okay, so we are trying to keep them as soon as much as possible. Okay, for the students who need lecture 25. Okay, this is lecture 25. 1 second. 1 second. Okay, here you go. This is lecture 25. Okay, this is the um, recording for lecture number 25. Okay, so if you guys want, please copy and paste this in your URL right away, and download the lecture if you need. Okay, because what happens is we only get a certain amount of space in Zoom in order for us to record the lectures. So we need to keep our spaces empty. So what we do is we download the lectures and then we send it out, but we still have lecture 25 in our gallery. So please um, view the lectures from our gallery in Zoom right away. How about the trial lectures? Once again, the trial lectures, the recordings for the trial lectures are not well. Okay, they are not properly recorded in order for you to watch the videos and learn from them. Okay, so what we said was, instead of providing you the trial lectures, okay, we will take it once again for you. We will take those lectures again for you, so that you guys do not have any difficulty in understanding any of the previous topics. Okay. Okay, no problem. Okay, so all you guys have to do is, let's say you guys face difficulties in a certain topic, just write down the name of the topic and send me an email. So what I will do is I will make a list of all the topics and then talk about them one by one. Talk about them one by one throughout the week. After the end of our lectures, we will take 10 to 15 minutes, and then we will talk about the difficult topics one by one. Let's say you find a topic difficult in endocrinology, you find a topic difficult in cardiovascular system, you find a topic difficult in let's say musculoskeletal system, and you send me the name of the topic, and I'll take the lecture once again. Okay, Dr. Naud, which lecture says it does not exist? Which one? Which one? Lecture 25. Okay, lecture 25 should exist because lecture 25 is, okay, once again. Lecture 25. Okay. Okay. Let me show you guys. Okay. Can you guys see my screen right now? Okay. Okay. So can you guys see my screen? Yes or no? Yes. Can you guys see my screen? Yes or no? Okay. So this is lecture 25, guys. Lecture 25 is still over here. Okay. So lecture 25 should work for you guys. If it doesn't, then I will send you the URL. So this is lecture 25. Okay, so once again, let me try sending you the link for lecture 25. Okay. Here you go. This is lecture 25. Okay, this should work because okay, we just opened it in front of you. If you guys still find it difficult to open the lecture, please let me know. I'll download the lectures and I'll send it to you via Google Drive. Okay. Okay, we received another question from Dr. Hussam. Okay, before we start our revision, let's answer Dr. Hussam's question. And his question was, in our real exam, how many or how much break time totally do we have? That's a very good question. That's a very good question. Okay, so the question asked by Dr. Hussam was how many hours do we get as a break? Okay. Okay, so first of all, let me ask you a question. How long do you think the USMLE Step 1 question exam is? How long do you think the USMLE Step 1 exam is? Fast answers, please. 8 hours, very good. Okay, 8 hours. The reason why I asked you the question is because to get your attention. Okay, so eight hours. So this is a very good question. And so basically what happens is in that 8 hours, how many blocks do you have? Do you guys have any idea about how many blocks you have? Good. 7. Exactly. So you guys have exactly 7 blocks. Each block has 40 questions. Okay, each block has 40 questions. So in altogether, you guys have to solve 280 questions in your entire time period of 8 hours. So what happens is you get 1 hour as break time. Okay, so what happens is if you guys can see my screen over here, let's say this is your exam. Let's say that this is your exam software. Okay, so you will have a software like this. You will sit in front of the computer. Okay, you will sit in front of the computer, and then you will have your headphones. Okay, and then you will have your screens, which are protecting you from the student beside you, depending on how severely coronavirus is taken, or depending on the severity on how coronavirus is taken in your country. And if it is, then either it could be only you in the room, or it could be you and 2 other people at max in the room. Okay, having said that, let's say that this is your screen, okay, and you are giving your exam over here. Okay, your block has started. After your block has ended, there is an end button at the end of your block. So once you end that, okay, so once you end your block, that block is over, and then your break time starts. Okay, your break time automatically starts. So your break time is exactly 1 hour. Okay, so you can decide to take, you can decide to divide that 1 hour into many ways you possibly can or you possibly want. Let's say you decide to take 15 minutes break after the first block. So you go outside, okay, you eat something, you go to the washroom, okay, you drink some coffee, you drink water, or do whatever you have to do, and then you come back after 15 minutes. But your break time is already going on. Okay, so after you come back and you start your second block, as soon as you start your second block, your break time pauses. Your break time pauses. Okay, and then you keep on doing your block once again. After you're done with your second block, as soon as you hit end, your break time starts again. Okay, your break time starts again. So this is how the 1 hour break is divided. Keep in mind that if you use the entire 1 hour, the next block will start by itself. Okay, so let's say you are in your third block, you are done with the block, and then you go outside, and let's say you go use the washroom or go outside to eat, and God forbid, you cannot come inside, or there's something wrong for which you are late to enter the hall or sit in front of your computer. Let's say if your break time ends, your fourth block will start all by itself, and the timing will keep on going on for the fourth block, and the timings for each block is 1 hour. Okay, and it will start by itself, and then it will end by itself if you do not complete the block. Am I clear? Am I clear about how the USMLE Step 1 exam will take place? Okay. Okay, good. So you will get a lot of help over there. Okay. There is absolutely nothing to be worried about. The Prometric centers are exceptionally arranged for students to give wonderful exams. Okay, they should have a lot of help around. Okay, but depending on the pandemic situation of the world, they will not provide you with your food. They will not provide you with your water. Okay, so that is something which you have to take for yourself. Okay, you will have to take your own food. You will have to take your own water, and that's that. Okay, but the usually the invigilators during the Prometric centers are extremely helpful. They're extremely helpful. They're very friendly. Okay, they know that you guys are tensed. They know that you guys are nervous, so they will help you out as much as possible. Okay. Anything else? Do we have any more questions? Do we have any more questions regarding the USMLE exam? Regarding the USMLE exams, do we have any more questions? If no, then we would like to, okay, now, no, okay. If no, then let's start our revision from yesterday, because we do not have a lot of time, because we have to start. Okay, if a new question jumps out, please let me know. And I'd be more than happy to answer it for you, okay? Okay, good. Are you guys ready for the revision and recapitulation from yesterday's lecture, please? Okay, okay, good. Okay, good. So before we begin, okay, before we begin, 1 second. Okay, give me 1 second, please. Okay, so let's begin our revision and recapitulation from yesterday's topics. Okay, we did a lot of high yield topics from yesterday, and we would love it if each and every one of you could remember. Okay, we don't have a lot of time, so we will keep it very short. Okay, we will keep it very short. First of all, what I would like to test you guys is, okay, what I would like to test you guys is, okay, so, okay. I'm pretty sure you guys know where this is going, okay. First of all, I would like to test whether all our students can understand the visual field defects, okay. Okay, what is this visual field defect? What is this defect? Okay, how did you guys know that this is the left side or the right side? How did you guys know that this is the left or this is the right? Okay, so what if I tell you that this is the left and this is the right? Then? Okay. Okay, no problem. Okay, so I'm gonna keep things simple. Left, right. So you guys are right? Okay, right answer. Okay, next one. Okay. What is this defect? Very good. Bitemporal hemianopia. Okay, next one is this with defect. What is the name of this defect? Left homonymous hemianopia. Where is the lesion? Which structure has been struck, or which structure has the lesion? Tract. Okay, what about this one? Where is the lesion? Okay, fast answers, please. We do not have a lot of time. Okay, it's Mears loop. Very good. Okay, next one is where is this lesion over here? Fast answers, please. Fast answers. Parietal lobe lesion. Okay, a dorsal optic lesion. Okay, next one is what is this lesion? Fast answers, please. Very good. Okay, what is this lesion? Fast answers, please. Okay, good. Okay. Okay. Next one. Next one, which I want to test is, okay. Next one, which I want to test is, okay. So you have two eyes over here. Okay. This is your frontal eye. This is your, okay, right frontal eye field, left frontal eye field. Okay. These are the eyes. Okay. You guys know where I'm going with this. Okay. Okay. What is the name of the structure A? What is the name of structure A? PPRF. What is the name of structure B? Okay. What is the name of structure C? C. What is the name of structure C? Structure C. Structure C is oculomotor nerve nuclei. Okay. Oculomotor nerve nuclei. Okay. Okay. And then from here, it goes to here. From here, it goes to here, then here. After that, this goes to here, and this goes to here, and then your eyes move this way. Okay. Then we have some two more structures. We have D, and then we have E. Okay. Which of these structures is the medial longitudinal fasciculus? Very good. Okay, very good. Okay, very good. Next one. Next one is, okay, okay. Okay, we're just going to draw a part of this structure over here. Okay. Okay. Which one of this is the sixth cranial nerve? Which one of this is the sixth cranial nerve? Sixth. Which one? Okay, good. Very good. Okay. Okay, good. Very good. Okay. Then what we would do is I would like to see if you guys remember another thing. Okay. Okay. Okay, give me 1 second, please. Okay. Okay, 1 second. Okay. Which one of this is the pretectal nucleus? Okay, which one of this is the Edinger-Westphal nucleus? Okay, which one of this is the ciliary ganglion? Okay, okay, okay. And which nerve is used for spinster pupillae? Which nerve? Well, what is the name of the nerve? Please don't tell me it's oculomotor nerve, please. Okay, it's not oculomotor nerve. Very good. It's short ciliary nerve. Very good. It's short ciliary nerve. Okay, good. Now, if I have to ask you guys about pupillary dilatation, where is the first order neuron? Pupillary dilatation is sympathetic or parasympathetic? Very good. So the first order neuron is in the hypothalamus. Okay, and what is the last order neuron? Last order neuron, or the third order neuron. Okay, which nerve is involved for pupillary dilatation? Nope. Which nerve is involved for pupillary dilatation? Dilatation. What is the name of the nerve? Long ciliary nerve. Very good. Long ciliary nerve. Okay, very good. Okay, so long ciliary nerve. Okay, okay, we do not have a lot of time. We only have 3 minutes, and in those 3 minutes, we will discuss something which is very, very high yield, and then we will move on. Okay, so far you guys are doing exceptionally well, so thank you so much. Okay, what are we drawing over here? What we are drawing is we are drawing the ophthalmoscope, ophthalmoscopic findings. Okay, if this is the ophthalmoscopic finding, then there's another thing over here, which is the physiological cup. Okay, over here, what we have is the optic disc. Okay, and over here, what we have is this is the macula. Okay, okay, and these are our blood vessels. Okay, this is what we see in a normal ophthalmoscope: macula, macula, optic disc, and the blood vessels. Okay, so right now, if I tell you, that there is macular degeneration, okay, and spots. Could you please tell me the diagnosis really fast, please? We don't have a lot of time. Okay, good. Okay, age-related macular degeneration. Okay, right now, the next one which we have is macular edema. We have macular edema and leakage. Leakage. Okay, well, what is the diagnosis? Very good. Okay, next one. Next one is we have spots and we have exudates. What is your diagnosis? Fast answers, please. Very good. Okay. Okay. Next one. Next one is okay. We have only 1 minute. Okay. Red. Okay. Engorged blood vessels. Engorged blood vessels. What is your diagnosis? Very good. Okay. Then what is this diagnosis? Spicules, bony spicules, retinitis pigmentosa. Very good. Next one is this one over here. Okay. What is this diagnosis? Okay. Very good. Very good. And have we missed out on anything? Oh, right. We have missed out on something. Okay. There's something, another thing which I forgot. That is this one. Okay. If there's swelling of the optic disc, papilloedema. Okay, good. It's 9:45 exactly, and we are done. Okay, we are done. So congratulations, you guys have successfully answered all the questions regarding ophthalmoscoping abnormal, ophthalmoscopic findings. Okay, so that's what it is. So you guys have done that. Okay. Okay. So thank you so much for putting your utmost attention during the revision and recapitulation. This helps me realize if we did a good job in making you guys understand, and if you did a good job in understanding the lecture. So looks like you guys have no problem understanding ophthalmology. Having said that, if you guys have any issues with the subject, please let me know. I will be more than happy to take the class once again for all the students who are facing difficulties. Okay, having said that, are we ready to begin our pharmacology lecture for today? Okay, good. Okay, very good. Okay, so let's begin. Let's begin. Okay, so this is first the monster table. Okay, how many of us are scared of this table? How many of us are scared of this table? Okay, I know I was scared, so I would say I'm scared. I'm not scared right now. If I was scared, then you should be scared. If I'm scared, because then you should be scared. Okay, so I'm not scared. I used to be scared about this when I would study this table. Okay, but I realize how easy this table is. Okay, if you guys are scared, that's absolutely good news because this should be very easy for you after the end of today's lecture, hopefully. Okay. Okay, so what we are going to do is we are not going to study this table um, as a whole. Okay, we are not going to study this table as a whole. So first of all, what we would be doing is we would be studying the drug. We would skip out on this thing for now. This portion of the table, we would skip out for on this portion for now. Okay, and then we would focus on this one at the end of this table. Okay, after the end of this table, we will focus on this part. So we will skip out on this. What we will be doing is we will be going straight from the drug to the mechanism. Okay, to the mechanism. So first we would be looking at all the mechanisms about how the drugs work. Okay, about how the drugs work. So first and foremost, okay, first and foremost, what I would be doing is I would be asking you guys, and I would be seeing whether you guys know whether you guys know the certain drugs all by themselves or not. Okay, one second. Okay, one second. Okay, thank God. Okay, okay, okay. So what we will be doing is we will be focusing on the mechanism of the drugs first. Okay, so let's begin. Okay, so the drug that I want to talk about. Okay, the drug that I want to talk about. Okay, so this drug. Okay, this drug. What this does is okay. One second. Okay, so let's say that this is a chloride ion channel. Okay, let's say that this is a chloride ion channel. Okay, okay, and now over here, okay, you have this receptor. Okay, you have these receptors. Okay, these are GABA receptors. Okay, okay. If I tell you that you have a drug which increases the duration of opening. Okay, increases the duration of opening. One second, please. Can you guys please give me 1 second? Okay, my apologies. Okay, so let's begin. So what we were talking was, let's say that this is a chloride ion channel. Okay, let's say that this is a chloride ion channel, and this is the receptor for gamma aminobutyric acid. Okay, and let's say if I ask you the name of one drug which will increase the duration of this opening, which will increase the duration. What do you guys think the name of this drug is, or which group of drugs do they belong to? Increasing the duration, barbiturate. Very good. And why is it called barbiturate? Okay, so what happens is the name barbiturate. Okay, barbiturate. Okay, barbiturate. So meaning that barbiturate or barbiturate, what they will do is they will increase the duration of opening of the GABA, and the chloride will keep on, and the chloride ion will stay open for a long period of time. Okay. Right now, if I tell you that you have another drug, okay, you have another drug which which instead of increasing the duration, okay, which instead of increasing the duration, it increases the frequency. Okay, it increases the frequency. So let's say the chloride ion opens and then the chloride ion closes again, and then the chloride ion opens and the chloride ion closes again, because it increases the frequency of opening of the GABA ion channel. Which one do you think the name of this drug is? Benzodiazepine. Very good. So the name of this drug is benzodiazepine. So first and foremost, these are the two main drugs which I wanted to talk about because they are very commonly used. Okay, so if we do not have any confusion, then I would like to do the revision on these two drugs. That is, first of all, the mechanism for benzodiazepine is increase in frequency of chloride ion channel, and barbiturate is increase in duration. Okay, are we clear? Increased frequency of the GABA channels, and barbiturate for increasing the duration of the GABA channels. And this is extremely high yield for USMLE step 1, because they will mention this in your question stem exactly how it is that you have a drug which is used for increasing the duration of the chloride ion channel by working at a receptor. They might not even tell you the name of the receptor, but if they tell you that it's a chloride ion channel and the duration is increased, then the drug is barbiturate. Okay, and we know a lot of examples of barbiturates. Can you guys tell me some examples of some of the names of the barbiturates that we use? Thiopentosodium, sodium, and then we have phenobarbital, then we have seclobarbital, pentobarbital, right? Exactly. And then some examples of benzodiazepines. Okay, what are some of the examples of benzodiazepines? We have diazepam, we have clonazepam, okay, then lorazepam, okay, good. So these are the drugs, okay, so benzodiazepine and barbiturates, so very good. Okay, the next group of drugs, okay, so we are done with the first one. So the first one, what is the mechanism of action? The mechanism of action is increasing the action of GABA, increasing the action of GABA, okay. Okay, next one, which I want to talk about, okay. As a matter of fact, we're done with two drugs from the table. Okay, we are done with benzodiazepine, and we are also done with phenobarbital. Okay, so phenobarbital is barbiturate, and benzodiazepine is the benzodiazepine one, which we just talked about. Okay, so we're done with two drugs. Okay, the next group of drugs that I want to talk about. Okay, the next group of drugs that I want to talk about is, you have another channel over here. Okay, now this channel, okay, so this, since it's an anti-epileptic drug. Epilepsy is basically discharge of asymmetric impulses from the central nervous system to the body, right? And the transmissions of those impulses, they depend on the proper functioning of the sodium potassium channels. Okay, so let's say that this is a normal sodium channel. Okay, so normal sodium. So normal sodium channel. Okay, normal sodium channel. Okay, okay. There is a drug which will block this sodium channel. Okay, so what happens is, if you block the sodium channel, then the impulses will not travel. Okay, the impulses cannot travel along the nerve. Okay, so The nerve that is used, the drug that is used for blocking this normal sodium channel, okay, this C over here. Can you guys guess what the name of this drug is? Can you guys guess what the name of this drug is? Carbamazepine and also phenytoin. Very good. So the names of these drugs are carbamazepine or also phenytoin. Okay, C and P. Okay, so both of these drugs, they work in the same mechanism. How do they work? They, first of all, they simply block the the sodium channel. Okay, they simply block the sodium channel. That's it. Okay. Now, if I tell you, that you have another drug, okay, you have another drug, okay. So what this drug does is, instead of blocking the simple channels, what they do is they block the voltage gated sodium channel. Okay, they block the voltage gated sodium channel. Okay, so and also what they do is, while blocking the voltage gated sodium channels, okay, while blocking the voltage gated sodium channels, they also want to make sure, okay, they also want to make sure that no excitatory neurotransmitters are being released. Can you guys give me some examples of excitatory neurotransmitters except adrenaline and norepinephrine? Okay, glutamate is an excitatory neurotransmitter. Very good. When was the last time we studied glutamate? When was the last time we studied glutamate? Basal ganglia. Very good. The last time we studied glutamate was basal ganglia. Okay, good. So that's that. Okay. So in order for excitatory or epileptic impulses to stop, okay, so this drug, what this does is, along with blocking the voltage gated sodium channel, it also decreases glutamate. Okay, so what happens is, if you decrease glutamate, there's less excitation, right? And so altogether, what this does is, this decreases the action of this decreases the signs and symptoms of your seizure and epilepsy. Okay, and the name of this drug, okay, and the name of this drug is, okay, it's very lame. Okay, then the name is very lame. It's a very lame drug. Okay, lame drug. Okay, we don't use it in the drug world. Everyone looks at it like, you're so lame. You can only block the sodium channels. Why are you blocking the sodium channels and decreasing the glutamate and stuff? And no one likes them. Okay, no one likes them at all. The name of this drug is lamotrigine. Okay, all those rants were mnemonics regarding lamotrigine. Okay, it's very lame. It's extremely lame to block the voltage gated sodium channels, and it's extremely lame to block the glutamate. He could just go and block the normal sodium channels like carbamazepine and phenytoin. Okay, but he always has to be extra, and he always goes and then he blocks the sodium channel and he decreases the glutamate. Okay, so what is the name of this drug? What is the name of this drug? Okay, okay. Lamotrigine. Okay, okay. It's a very lame drug. Okay, so lamotrigine. Or that's what it is. So it's not pronounced as lamotrigine. It's pronounced as lamotrigine. Okay, lamotrigine. So, but since it's so lame that it has to block the voltage gated sodium channel, along with the fact that it has to also decrease the transmission of glutamate. All this extra work is extremely lame. Okay, so he is lamotrigine. Okay, next one is, there's another drug who is on the top of the game. Okay, so he's at the top of all the sodium channel blockers. Okay, so we have our regular carbamazepine and phenytoin, which is blocking the sodium channels, and then we had the lame drug over here blocking the voltage gated sodium channel and also stopping the glutamate. But we have this another drug which is the top of the sodium channel blockers. Okay, why is he at the top of the sodium channel blockers? So this drug, he's at the top of the sodium channel blockers because not only does he block the sodium channel, this great drug over here, also what this does is this increases in inhibitory neurotransmitter, that is GABA, that is GABA. Okay, so not only does it block the sodium channel, this drug who is at the top of the game, he goes and then he blocks the sodium channel, and also he increases the GABA level. As a result, what happens? Your impulse transmission decreases severely. Okay, so this is extremely this is an extremely top of the top of the game mechanism for stopping your epilepsy. Okay, so what is the name? What do you think the name of the drug is, which blocks the sodium channels and increases the GABA? Topiramate, very good. So topiramate, they're at the top of the sodium channel blockers. Okay, so they are at the top of the sodium channel blockers. Okay, okay, okay. So since we are talking about GABA, okay, since we are talking about gamma aminobutyric acid, okay, okay. Now the thing is, do you guys know the name of the drug which breaks down GABA? Do you guys know the name of the drug which breaks down GABA? I mean, the name of the enzyme. My apologies. The name of the enzyme which breaks down GABA. What is the name of the enzyme which breaks down GABA? Anyone? The name of the enzyme that breaks down GABA is GABA transaminase. Okay. Okay. So what is the name of the drug? What is the name of the enzyme that breaks down GABA? The name of the enzyme is GABA transaminase. Are we clear? Are we clear? Okay. So if I increase GABA, okay, if GABA is increased, will there be more epilepsy or less epilepsy? If GABA is increased, will there be more epilepsy or less epilepsy? Very good, less epilepsy. Why? Is GABA an excitatory or an inhibitory neuron? Inhibitory neuron. Okay, so if I block GABA transaminase, will this increase GABA or decrease GABA? If I block GABA transaminase? Okay, okay. So the next drug that we want to talk about, okay, so the next drug that we want to talk about has nothing to do with sodium channels, but it works on GABA transaminase, okay? It works on GABA transaminase, okay? So what this does is, okay, this drug blocks GABA. Well, what is the name of this drug? What is the name of this drug? Valproic acid. Okay, very good. Or as we would like to call it, block acid. Why would we call something block acid? Because you guys know that I have a tendency of doing this. I have a tendency of changing the names of certain things according to how I like it. Okay, you guys do not have to do it yourself. I personally like to change the names about different drugs and different things so that it helps me remember about the names and the mechanism. So who is this drug? This drug, according to me, is block acid. Okay, that's what I'm going to call. Okay, or in the exam, you have to answer as valproic acid. So valproic acid or block acid, what does it does? What does it do? It inhibits or it blocks GABA transaminase. As a result, GABA is increased. Okay. As a result, GABA is increased. Okay. Next one. Next one is next one is next one is this Val guy over here. Okay, this Val block drug has a brother. The name of that brother is okay. The name of that brother is okay, Vega. Okay, what does the brother do? What this brother does is okay. This is a he. Okay, so he's a younger brother. Okay, so this guy he is a younger brother, and what this guy does is he always wants to take things up one notch. Do you know how we have little brothers? How many of us have little brothers over here? How many of us have little brothers? Or how many of us are the older sibling? Do we have any older siblings over here? Okay. Okay, so if you guys have your younger brothers, okay, your if you do something, your younger brother will copy you and then try to do something extra to look good in front of your parents. Am I correct? Yes or no? Okay. Okay, yes. So, okay, these are the tendencies of young brothers. Absolutely annoying. Okay, right. So what this guy would do is, Val block acid told him that, do not worry, I have increased the GABA by I have blocked the GABA transaminase. And then he goes like, no, blocking the GABA transaminase is not enough. I have to kill it. So he takes things one he takes things one notch up. Okay, he takes things very seriously. He goes and then he kills GABA transaminase. So what does he do? He irreversibly inhibits transaminase. So what is irreversible inhibition? Okay, so irreversible inhibition. So he literally goes and then he kills GABA transaminase. Irreversible inhibition of GABA transaminase. Okay, have we understood? So he always have to think, he always have to take things one notch up for no reason. So if valproic acid was telling him that he has it under control, he has increased the GABA, okay, but he always has to take things one notch up, and then he has to go like, okay, no, you blocked him, but I will kill him. Okay, so he goes and then he kills him. Okay, so Vega goes and then he kills GABA transaminase. As a result, GABA increases. Are we clear? Are we clear? Okay. If we are clear, can I do a small revision and recapitulation? Okay. Please feel free to unmute yourselves and answer the question because this will save me some time. Okay. Okay. And we will rerun the whole story. Okay. We are done with most of the drugs. Okay. We are done with most of the drugs. Okay. 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 So can you guys hear my voice? Yes or no?
Yes.
Okay,
Yeah.
perfect. So let's start with the small revision of the names of the drugs according to the mechanism of action. First of all, this is the chloride ion channel. You have a drug which increases the duration of the GABA. What is the name of this drug, please? Fast answers.
Barbiturate.
Very good. For next one is you have another drug which increases the frequency. Increase the frequency. What is the name of it?
Benzodiazepine.
Very good. Next one is we have this one drug over here which works on the sodium channel only, normal sodium channel, okay, which blocks the sodium channel. And we have two drugs which works like this. What are the names of these two drugs?
Carbamazepine and phenytoin.
They only block the they only block the
Calcium channel.
right.
Sodium
And then
channel.
right, they only block the sodium channel. Next one is we have this another drug. Okay, do not tell me the name of this drug, just let me draw it out. Okay, so this is the voltage gated sodium channel, and this drug, he's so lame that he has to block the voltage gated sodium channel, and along with this he also has to decrease what is he going to decrease? What is he going to
Glutamate.
glutamate? Okay, so what is the name of this name of the drug?
Lamotrigine.
Okay, lamotrigine. Very good. Okay, next one is your voltage gated sodium channel. Okay, okay, and this drug over here, okay, drug is at the top of the game. Okay, this drug is at the top of the game. So what this will do is he saw how carbamazepine worked. Carbamazepine blocked the sodium channel, phenytoin blocked the sodium channel, then the lame drug came and blocked voltage gated sodium channel and decreased the glutamate. But this drug, since he's at the top of the game, he knows that he can block the sodium channel, and at the same time he will also decrease your he will
Increase.
also increase your
Increase the GABA.
right. He will also increase your GABA. So who is this drug over here at the top of the game? What's the name of this drug?
Topiramate.
Topiramate. Very good. Then we have another drug over here. Okay, since we are talking about GABA, now we will talk about the brothers. Okay, we have the first brother over here. Okay, what does he do? He inhibits or blocks GABA transaminase. He's the big brother. Okay.
Block acid, yeah.
Okay, what's the name of this drug?
Valproic acid.
Valproic acid, and valproic has a little brother, okay, who wants to go and kill him, and he wants to kill transaminase. Okay, irreversible inhibition. What's the name of the little brother?
Vigabatrin.
Vigabatrin, yeah.
Very good, vigabatrin. Okay, good. Okay, thank you so much for participating. And these are the drugs that we have learned up till now. Okay, unfortunately, we still are not done. We still have some drugs left. Okay, and another important drug which I want to talk about. Okay, so another important drug which I want to talk about is is, one second, okay, let me just clear things out. Okay, so this drug, even before I tell you the name of this drug, if I draw out a scenario, you guys can easily answer the name of this drug based on how much emphasis this was put on in your basic science. I mean, your bachelor's of medicine and bachelor's of surgery education. Okay, so this drug is used. Okay, so what is the name of this drug which is used to treat a type of seizure in which the seizure usually occurs in a young child who stares into the abyss in the middle of the class and keep on staring away? Very good. Very good. Okay. The name of the drug is ethosuxamide. The name of the drug is ethosuxamide. Ethosuxamide is the name of the drug. And what was the name of the seizure that I have just discussed or I have just mentioned?
Absent seizure.
Very good. So ethosuxamide is the name of the drug, and ethosuxamide is used for absent seizure. Where does ethosuxamide work? Okay. Fortunately, ethosuxamide has the word, okay. What does THA mean? THA stands for thalamus. Okay, thalamus. Okay, the thalamus have T-type calcium channel blockers. Okay, so T-type calcium channel blockers. Okay, I will go into details about all the calcium, all the types of calcium channels. But for right now, for just understanding, just keep on remembering on the T-type calcium channel blockers for ethosuxamide. Ethosuxamide once again has THA for thalamus. Thalamus has T-type calcium channel blockers. So ethosuxamide blocks the T-type calcium channel blockers. Are we clear? Did we understand? Yes or no? Okay, let me see. Yes or no?
Yes.
Okay, very good. Okay. Next one is another last group of drug. Okay, next one is another group of drug, and that drug is not that high yield. Okay, but since it's there, okay, let me just see if I remember the mechanism of action well, because 1 second. Okay, so we have, what did we discuss? We discussed benzo, carbamazepine. Okay, we have not discussed this. We will discuss this. We have discussed the LAMO. Okay, then we have discussed this one. Okay, we have discussed this, and then obviously the two brothers, old one, big one. Okay, the next drug that we will discuss is this one. Okay, gabapentin. Okay, and how does GABA work? Okay, gabapentin. I'm sorry?
Phenobarbital. Sorry.
We already discussed.
No, it was not a question. I did not ask you guys a question. I was going to explain how the GABA works. Okay, so okay, do not worry. But thank you for the answer. Okay, so once again, so just let me hear the answer very quick. How does GABA work? If you guys know, how does GABA work? Now it's a question. What is the answer? How does GABA work? Okay, so no one knows. Okay, gabapentin. Okay, gabapentin works like gabapentin. If I told you that gabapentin works like glutamate, will you believe me? Yes or no? If I tell you gabapentin works like glutamate, will you believe me? Yes or no? Can I get some answers, please?
Oh, no.
Yes or no? No. If I tell you gabapentin works like GABA, will you trust me? Yes or no? Will you believe me? Yes or no? Yes. No. Okay, Dr. Jordan said no, but okay, then you have to believe me, Dr. Jordan, because gabapentin actually does work like GABA. Okay, because gabapentin is a GABA analog. Okay, gabapentin is a GABA analog. So what do GABA analog do? They inhibit the voltage. They work on the chloride ion channel. That's number one. And along with this, the gabapentin, what they do is they primarily inhibit the calcium channels too. Okay, they primarily inhibit the calcium channels too. And since they work on the calcium channel and also on the chloride ion channel to some extent, I'm pretty sure you guys know where I'm going with this. The name which I have for gabapentin is actually gabapentin. Okay. Why do I like to call gabapentin carbapentin? Because gabapentin works as a GABA analog and it also blocks the calcium channel. So Ca for calcium channel. Okay. Are we clear now? Are we clear now?
Yes, thank
Yes
you.
or no? Gabapentin works as a GABA analog. It increases the chloride channel openings. That's working as the GABA analog, but primarily it inhibits the calcium ion channels, the calcium ion channels. So that's why we like to call our gabapentins as carbapentins, C-A-B-A, carbapentins. Are we clear?
Yes.
Everyone, can I get yes from everyone to understand if they have understood? Yes or no? Okay, thank you. Okay, that's what it is. Okay, last drug is over here. That is levetiracetam. Okay, last drug is levetiracetam. And how does levetiracetam work? Levetiracetam, okay, blocks a very important receptor that is SV2A. Okay, and we will talk about this in 1 second. Okay, but there's another way how levetiracetam works. Okay, levetiracetam. Okay, do you remember how we talked about lamotrigine? Okay, can anyone please unmute themselves and tell me the mechanism of action of this lame drug, please?
Yes, it decreases glutamate and increases GABA.
It decreases glutamate and which
And
Block calcium, block sodium channel.
yeah,
Block,
and block sodium channel.
okay,
block
so
voltage, sodium.
Voltage, yeah.
Voltage, yeah.
it blocks the voltage gated sodium channels and it releases and it inhibits the release of
GABA, glutamate, sorry.
Glutamate.
Glutamate, yeah.
Okay, so levetiracetam, okay, levetiracetam is who is levetiracetam? Levetiracetam is the wife of lamotrigine, okay? And levetiracetam does the same thing which he does, except the fact that he blocks sodium and she blocks calcium.
Calcium.
Very good. Okay. And both of them inhibits the release of glutamate. Both of them inhibits the release of glutamate. He decreases the release of glutamate. She decreases the release of glutamate. He blocks sodium channel. She blocks calcium ion channel. Okay. SV2A receptor blocker. I will talk about this in the future, but for now, this is the basic mechanism of action. Okay. Okay. Now what I would do is, since I have discussed all the drugs mechanism of actions, okay, since I have discussed all the drugs mechanism of action, I will give you guys 1 minute. And okay, 1 minute, not even 1 minute, I will give you guys 30 seconds to just go through the mechanism of action in the table. Okay, go through the mechanism of action from the table. And I would need the help of 2 doctors who will tell me the names of the drugs, and I will tell them the mechanism, and they will tell me the names according to the mnemonics that we have just used to understand. Okay, did you guys understand all the drugs? Okay, you didn't get the last thing. The last thing was levetiracetam. Levetiracetam is the wife of lamotrigine. Lamotrigine blocks sodium channel, voltage sodium channel. Levetiracetam blocks voltage calcium channels. Lamotrigine blocks the release of glutamate. Levetiracetam blocks the release of glutamate. Are we clear? Are we clear? Okay. Okay, so take 30 seconds, read the mechanism of actions, and then I will need the help of, okay, 2 or 3 doctors who will tell me the names of the drugs. Okay, so 30 seconds. Okay, are we done? Is anyone done? Okay, we have Dr. Hussein who is done. Anyone else? Okay, okay, good. So let's begin. Okay, so first thing that we're going to draw is a chlorodyne channel. Okay, anyone can participate, no problem. Just tell me the right name of the drug. Okay, this is
Okay.
the GABA channel. Okay, we have a drug increasing the duration. Name,
Barbiturate.
increasing the frequency. Name.
Benzodiazepine.
Okay, next one is sodium channel. Straight away blocks simple sodium channel. Name.
Carbamazepine and phenytoin.
Then blocks the voltage gated sodium channel and also has to decrease the glutamate.
Lamotrigine.
Lamotrigine. Lame.
Lame drug over here. Okay, I hate this drug. Okay.
Yes.
Next one. Next one is the wife of lamotrigine. Blocks the voltage gated calcium channel and decreases glutamate. What is the name of this drug?
Levetiracetam.
Okay. Okay. Good. Next one. Next one is okay.
Lamotrigine, yes.
Okay. The two brothers. Okay. One
Increase.
stops GTA, stop or blocks. What is the name of this drug?
Valproic acid.
Okay. Another one kills. Okay, good. And then we had another drug over here. It was at the top of the game. How they would block the voltage gated sodium channel and they would increase
Tubramate.
increase GABA.
Tubramate, yeah.
What is the
Increase
name?
GABA. Tubramate.
Topiramate. Very good. The name of this drug is topiramate. Then we had another drug which worked on the thalamus.
Ethosuximide.
Ethosuximide.
Okay, ethosuximide. Very good. Next
Ethosuximide,
one.
yeah.
Next one is we have, okay, another thing is, did we leave anything out? Oh, right, we left another one out. Okay, that is this one, or we like to call it.
Calcium.
GABA.
Okay, what's the mechanism of action of gabapentin?
GABA analog.
Sodium channels and GABA.
Calcium.
Inhibits the high voltage calcium channel.
Very good. Okay. Okay, good.
Gabapentin, yeah.
Okay, so having said that, we have learned about all the mechanisms of the drugs. Okay. Okay, are we clear about all the mechanisms of the drugs? Are we clear about all the mechanisms of the drugs? Yes or no?
Yeah.
Okay, so thank you so much for participating. I'm going to mute you guys right now and then. Okay, so thank you so much for participating. Okay, so does this make the mechanisms easy or does it make it more difficult and confusing? Okay, I'm happy it makes it easy. Now, the next thing which we will move on to is the side effects. Okay, now we'll move on to side effects. Okay, and the side effects we will learn. Okay, I'm pretty sure you guys know most of the side effects. Okay, first of all, benzodiazepine and phenobarbital. Okay, since they both work on the GABA channels, one increases the duration, one increases the frequency. Their side effects are more or less the same. So both of them cause. We know why we use benzodiazepine. Okay, we know why we use benzodiazepine. Okay, we use benzodiazepines too for your sedations. Okay, so it's also used to induce sleep. So it's used for sedation. It's used for epilepsy, right? And the side effects are sedation. Then you can get tolerance. Okay, so if you keep on having the drug for a long period of time, it will not work. Then the patients can get dependent. Okay, and we also know that these drugs can cause severe respiratory depression. Okay, which one of them cause more respiratory depression, barbiturate or benzodiazepine? Fast answers, please. Which one of them causes more respiratory depression? Benzodiazepine or barbiturate? Which one? Barbiturate, very good. Benzodiazepine does not cause as much of the respiratory depression as barbiturate does. So barbiturate causes more respiratory depression, but benzodiazepine also causes respiratory depression to some extent. Okay, okay, good. So we are done with the side effects of two drugs. So this also causes your sedation, tolerance, okay, and then respiratory and cardiorespiratory depression. Also, barbiturate is also a cytochrome P450, okay, inducer. It's also a cytochrome P450 inducer, okay. And what we will do is we will learn all the cytochrome P450 inducer by themselves, okay. So we don't have to address this over here right now. We can address this later, okay. Next one I want to talk about is carbamazepine. Carbamazepine, we know exactly what carbamazepine does. Okay, one of the most important side effects of carbamazepine is Stevens-Johnson syndrome. Okay, so we have to be very careful about carbamazepine. And do you guys remember we talked about Stevens-Johnson syndrome in our dermatology lectures? Yes or no? What's Stevens-Johnson syndrome? What is Stevens-Johnson syndrome? What is Stevens-Johnson syndrome? Do we have blisters and everything in Stevens-Johnson syndrome? Yes or no? Blisters and skin reactions, right? Necrosis. Okay. What are the three stages of dermatological drug reaction? Three stages. We talked about them. 1, 2, 3. One was erythema. Erythema. What? Erythema marginatum or erythema multiforme. Very good. The next one. The next one is Stevens-Johnson syndrome, and the last one is, if you don't control Stevens-Johnson syndrome, then you get 10. 10 is toxic epidermal necrolysis. Okay. Okay. Very good. So one of the most important side effects of carbamazepine is Stevens-Johnson syndrome. Okay. Carbamazepine is also very damageable. Okay. It also damages the bone marrow. Okay, so what this does is this causes aplastic anemia, this causes agranulocytosis. Okay, and this is very important. And should we give carbamazepine to pregnant women? Yes or no? No. Why should we not give carbamazepine to pregnant women? We should not give carbamazepine to pregnant women because this is teratogenic, and this causes cleft lip, cleft palate, and spina bifida. Okay, spina bifida. So once again, what are the side effects of carbamazepine? What are the side effects of carbamazepine? Fast answers, please. I need some fast answers because I have to move on. Stevens-Johnson syndrome, and then agranulocytosis, and then teratogenicity. These are the most important side effects of carbamazepine. Okay, good. Okay, good. Next one is ethosuxamide. And ethosuxamide, I love the fact that how first aid use EFGHIJ for the side effects mnemonics of ethosuxamide. That is, ethosuxamide causes fatigue, GI distress, headache, itching, and Stevens-Johnson syndrome. EFGHIJ. Okay, so it causes fatigue, GI distress, headache, itching, and Stevens-Johnson syndrome. Out of all of this, the most important side effect for ethosuxamide, once again, is Stevens-Johnson syndrome. Okay, keep in mind most of the anti-epileptic drugs will cause Stevens-Johnson syndrome. Okay, so Stevens-Johnson syndrome is a very common side effects of the anti-epileptic drugs, except benzodiazepine and barbiturate. Most of them are bound to cause Stevens-Johnson syndrome. Okay, next one is gabapentin. Gabapentin is easy to understand since it works as a GABA analog. Okay, we know that GABA is an inhibitory neurotransmitter. If you have a lot of inhibitory neurotransmitter, will you be excited or will you be inhibited? Fast answers, please. If you have a lot of GABA, will you be excited or inhibited? If you are inhibited, will you try to sleep or will you try to run around? Fast answers, please. Sleep. Okay, so gabapentin causes sedation. Okay, gabapentin causes sedation. It also causes ataxia to some extent, but that's not very high yield. The most important one is it causes sedation. Okay, next one. Next one is lamotresin. Okay, the lame drug which had to block the sodium channel, voltage channel, and then it also decrease the release of glutamate. Okay, so lamotrigine. Lamotrigine, number one side effect, once again, is Stevens-Johnson syndrome. Okay, very easy to understand that it causes Stevens-Johnson syndrome. Along with this, it also causes another condition. This is known as hemophagocytic lymphohistiocytosis. Hemophagocytic lymphohistiocytosis. Did we study about this in? Did we study about lymphohistiocytosis in your blood chapter? Yes or no? Yes or no? What is hemophagocytic lymphohistiocytosis? What is hemophagocytic lymphohistiocytosis? Okay, so normal terms, okay, very good. So in normal term, what this is normally, in normal term, hemophagocytic lymphohistiocytosis is an abnormal inflammatory uh, hyperactivity, meaning that there is some sort of a cytokine storm, which results in overactivation of the white blood cells, especially the macrophage and the lymphocytes. And what this does is it goes and it starts attacking the blood products. It can attack the red blood cells. It can attack the platelets. Okay, as a result, patients have a life-threatening aplastic, pancytopenia-like condition. Are we clear about hemophagocytic lymphohistiocytosis? Yes or no? Yes, once again, hemophagocytic lymphohistiocytosis is an abnormal, abrupt, inflammatory storm in which there is excessive activation of the lymphocytes and excessive activation of the macrophage. As a result, there is phagocytosis of the RBCs, WBCs, and platelet. Are we clear? Are we clear? Okay, good. Next one is the wife of lamotrigine over here, Levi, okay, or levetiracetam. Okay, what this does is this causes neuropsychiatric changes or personality changes. And the way you can try to remember this is, first of all, lamotrigine. Okay, lamotrigine. Why lamotrigine gets very upset. Lamotrigine gets very upset when we call it lame. Okay, so what this does is he bursts up, and then he tries to cause damage to us. Okay, like hemophagocytic lymphohistiocytosis. He goes like, okay, so you're calling me lame. See, okay, now look and wait and watch. See what I do. Okay, and he will try to activate the macrophage and lymphocytes, and then he will try to destroy you. Okay, he will try to destroy you. So this is your lamotrigine. Okay, and this is what he does. Okay, and the wife of lamotrigine, that is levetiracetam over here. Okay, and who also blocks the voltage-gated sodium channel, the calcium channels, and also decreases the release of glutamate. Okay, so what this does is when lamotrigine starts acting all crazy, okay, his wife comes in front of him, and then he has a sudden personality change. Why does he have a sudden personality change? Because he is afraid of his wife, like every one of us. Okay, like every one of us, how we are afraid of our wives. Lamotrigine is afraid of his wife, and lamotrigine has a sudden personality change. So this personality change is due to the effect of levetiracetam, and levetiracetam causes the personality change in lamotrigine. So this is the neuropsychiatric symptoms which levetiracetam causes. Okay, so once again, lamotrigine starts acting all crazy. Okay, he wants to go and kill us, and then he comes in front of his wife. He gets scared, like how we get scared by our wives, and then levetiracetam induces a personality change. Okay, so levetiracetam is your drug which is causing the neuropsychiatric symptoms. Okay, next one. We already talked about phenobarbital over here, so we're done. Okay, next one is phenytoin or phosphenitoin. Phenytoin, okay, phenytoin also has the adverse effects with the initials. Well, what are the initials? Cytochrome P450. Okay, inducer, and we said we will talk about this all together, so nothing to be worried about. After that, it also causes H for hirsutism, meaning increased growth of body hair. enlarged gums, okay, enlarged gums and phenytoin, and this is extremely high yield. Okay, you will get questions in which you will have a picture where, okay, 1 second. You will have a picture like this. Okay, you will have a picture like this, which is called gingival or gingival enlargement. And if they ask you which drug is causing this type of gingival enlargement, the drug that is notorious for causing this is phenytoin. Okay, so phenytoin can cause enlarged gums. Patients can also get nystagmus. Okay, and the yellow-brown skin, teratogenicity. These are not that high yield. They can also cause fetal Hyde-Antoine syndrome. Okay, not that high yield, no problem. The most high yield is enlarged gums. After that, another high yield is inhibition of folate absorption. So please underline the high yield, inhibition of folate absorption. And they can also cause neuropathy, and obviously since it's an anti-epileptic, it will cause uh, your Stevens-Johnson syndrome. Okay, Stevens-Johnson syndrome. And they can also cause DRESS syndrome, and we talked about this in our UWorld notes. DRESS. Okay, what does DRESS stand for? What does DRESS stand for? DRESS, DRESS. You got these questions in UWorld. Okay, good. What does DRESS stand for? DRESS. We talked about this in UWorld notes. Drug reaction with eosinophilia and systemic syndrome. Do you guys remember that? Drug reaction with eosinophilia and systemic syndrome? Yes or no? We talked about these drugs. If you guys do not remember, please go to your UWorld notes, and then you can see the names of all the drugs that I have written down over there. Okay. Next. Okay. Good. Next one is, okay, topiramate. Okay, topiramate is the top of the drug. Okay, why is this the top of the drug? Not only does it block the sodium channel, it increases the GABA action. Okay, increases of GABA. So it's a beautiful drug. So it's at the top of the game. Okay. So and if topiramate is the word T, if topiramate is the word T, okay, what is the alphabet that comes before T? Fast answers, please. The alphabet that comes before T. S. Very good. The alphabet that comes before T is S, and S is the alphabet which is used for all the side effects. So, what are the side effects of topiramate? Sedation, slow cognition, kidney stones. Okay, out of this, kidney stone is very important. Okay, then slight threatened glaucoma. Okay, it also causes glaucoma to some extent, and speech difficulties. Out of all of this, if you have to remember one side effect, the one side effect is kidney stones. Okay, it's used for kidney stones. Okay, good. Next one is valproic acid. Okay, valproic acid. Okay, what was the mechanism of action of valproic acid? Can I get some fast answers, please? Fast answers on the mechanism of action of valproic acid. Does it kill GABA transaminase or inhibit or block? Inhibit. Okay. How about his younger brother? How about his younger brother? Kills. Okay, so what is the name of his younger brother? Okay, so the name of his younger brother is vigabatrin. Okay, and the mechanism, I mean, the side effect of valproic acid. Okay, what are the side effects of valproic acid? The side effects of valproic acid are, okay, GI distress. Okay, and the thing with this valproic acid, they try to attack two organs. Okay, they try to attack two organs. These organs are your liver and pancreas. Okay, so valproic acid tries to attack the liver. They also try to attack the pancreas. And can we give valproic acid in pregnancy? Yes or no? We know there are some teratogenic drugs which we cannot give in pregnancy. Can we give valproic acid in pregnancy? Yes or no? No. Why? Valproic acid can cause, okay, neural tube defects. Valproic acid can cause neural tube defects. What was the another drug that we just talked about, which we cannot give in pregnancy? What was the another drug that we talked about? Very good. Carbamazepine. Cannot give carbamazepine in pregnancy. Okay. Next one is vigabatrin. Okay, vigabatrin. Okay. Vigabatrin. Okay. Okay. Next one. Next one is, have you guys heard of this creature called bat? I'm pretty sure you guys have heard. Okay. I'm just asking you this. Okay. It's just a rhetorical question. Do you guys know what a bat is? Bat? What is a bat? Okay. I'm pretty sure you guys all know what bats are. Can bats see or no? Are bats blind or not blind? Bats are not blind? Yes, bats are blind. Okay, so I know exactly what bats are. Okay, bats are blind. Vigabatrin, it causes permanent visual loss. Okay, Vigabatrin causes permanent visual loss. So you can also go blind if you have Vigabatrin. Okay. 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 So now fast answers. Fast answers. First of all, what are the names of the drugs which causes sedation, tolerance, dependence, respiratory depression? What are the names of these drugs? Fast answers, please. Can I get some fast answers? Fentanyl and Barbie. Very good. What is the name of the drug which attacks the bone marrow, causing agranulocytosis? We cannot give them in pregnancy. Okay. Carbamazepine. Very good. What is the name of the drug? What is the name of the drug which causes? Do you remember the name of the drug which causes hemophagocytic lymphohistiocytosis? Because he is called lame. Okay, good. Lamotrigine. And then lamotrigine sees another drug and gets a sudden psychiatric change. Okay, because that drug is wife of lamotrigine. Okay, levetiracetam. Very good. Then you have another drug which causes enlarged gums. What is the name of that drug? Enlarged gums. Gum enlargement. Phenytoin. What is the name of the drug? What is the name of the drug which causes kidney stones? Kidney stones. Very good. Um, what is the name of this drug which attacks your liver and pancreas very frequently? Valproic, very good. Valproic acid. And then the bat drug, okay? Then the drug with the name bat in it, and you can get permanent visual loss. Vigabatrin. Okay, Vigabatrin. Okay. Next one. So we are done with the side effects. Okay, we are done with the side effects. Next is what we want to talk about are which drugs are used in which types of epilepsy. So we talked about all these epilepsies in the past. We talked about focal, tonic-clonic, absence, and status epilepticus. Okay, so first of all, let's talk about, okay, so the stars over here. So 1 star is used for commonly used, 2 star is used for first line, and 3 star is used for recurrent. Okay, so according to this one, so that's what it said. Okay, so for the first type of seizure, okay, which is the partial seizure, what the best way you can remember all the drugs that are used for partial seizures are trying to remember all the drugs that are not used for partial seizure. Okay, if that makes sense. So the drugs that are not used for partial seizures. Okay, let me use another color. Okay, let me use another color. So what are the drugs that are used for partial seizures? The drugs that are used for partial seizures are all the drugs except
My dear.
كيف استنى ما تجري كذا
My dear. My
okay. I'm gonna ask you to mute now. Okay. When I ask questions, only then unmute yourselves. Okay. Thank you. Okay. So the first one, so for partial seizures, we can use all drugs except benzodiazepine and ethosuximide. Okay, we can use all drugs except benzodiazepine and ethosuximide. Okay, so we cannot use them. So what are the drugs that we can use for partial seizures? Fast answers, please. Can I get some fast answers? Can I get some fast answers? What are the drugs we can use for partial seizures?
carbon
Okay. All drugs except benzodiazepine and ethosuximide. Okay, very good. Okay, good. Next one. Next one is for tonic-clonic seizure. Okay, for tonic-clonic seizure. before we move on to tonic-clonic seizure, out of all the drugs that we use for partial seizure, the most commonly used is carbamazepine. Most commonly used is carbamazepine, and we know what focal seizures are. Focal seizures basically, if this is your brain, then only one part of the brain is has a foci. Okay, that where the problem is, and from there you have the seizure. Okay, this could either be a tumor or like anything else. Okay, next one. Next one is a tonic-clonic seizure. Tonic-clonic seizure, we all know what tonic-clonic seizure is. Once again, tonic-clonic seizure, we can use all the drugs for tonic-clonic seizure, except, once again, benzo, ethosuxamide, and also we will add another drug, okay, that is gabapentin, okay? So gabapentin. So, okay, even vigabatrin is not used, okay? So the thing is, we will not talk about vigabatrin for anything else. We will talk about this in the at last, okay, because vigabatrin itself is only used for one seizure only, and that is for partial focal seizure, okay? So we will talk about this in the last. When we talk about all the drugs, okay, keep in mind that we're talking about all the drugs except vigabatrin. So once again, for partial seizures, we use all the drugs except benzodiazepine and ethosuxamide. For tonic-clonic seizure, we use all the drugs except benzodiazepine, ethosuxamide, and gabapentin. Next one is absent seizure. Absent seizure, we all know which drug is most commonly used. That is ethosuxamide, okay? But you will also like to know that we can use valproic acid. So valproic acid and ethosuxamide are your number one drug for absent seizures. Okay, we can also use lamotrigine, okay, but it's not that highly asked. But for absent seizures, we only use 3 drugs. What are the 3 drugs? Valproic acid, lamotrigine, and ethosuxamide. Okay. Next one is status epilepticus. And now we all know what we use in status epilepticus. I told you guys that we would like to use parectal diazepam because we cannot get access to IV or we cannot get access to IM. Okay. So for status epilepticus, we use benzodiazepines only, first line. And then we can also use for recurrent, if it's a recurrent seizure, let's say it keeps on happening. If benzodiazepine fails, then we can use phenytoin. Along with benzodiazepine, of course, we can use phenobarbital because they have the same mechanism of action, more or less. One increases the duration, another one increases the frequency. So that's that. Okay. Okay, once again. So, once again, okay. Okay, once again, can I get some fast answers, please, from everyone? You can use your voice to give me the answer. What are the drugs that are used for partial seizures? What are the drugs that are used for partial seizures? Fast answers, please.
All drugs except the
Except benzodiazepine and
benzodiazepine and ethosuxamide.
Very good. Next one is for tonic-clonic seizures. What are the drugs that can be used?
All the drug.
Ethosuxamide and gabapentin.
Oh, very good. Okay. Next one is for absent seizures. What are the 3 drugs that we use? Fast answers, please.
Ethosuxamide, lamotrigine, and the barbaric acid.
Okay. Next one is status epilepticus. What is the first line of drug that we use for status epilepticus?
Benzodiazepine and phenytoin second line.
Okay, perfect. Thank you so much for participating. And that's all. Okay, having said that, we only have last one. Okay, this is only the last thing left. That is some of the high yield notes. So for benzodiazepine, it's also used for eclampsia. Okay, but always remember that for the first line treatment for eclampsia is Maxalf or magnesium sulfate. Okay, magnesium sulfate. Next one is for carbamazepine. Carbamazepine, we have already talked about. There's the first line drug, the first line for it's used as the first line for trigeminal neuralgia. Okay, we talked about trigeminal neuralgia before. Okay, in which you have excessive irritation and activation of the trigeminal nerve. Okay, so that's that. Okay, next one is gabapentin. It's used for post-herpetic neuralgia. It's not that high yield. What's high yield is this line over here, phenobarbital. Phenobarbital can also be called phenobarbital. Why? Because it's used for the first line for seizure in neonates. In neonates, it's used as the first line for seizures. So that's why it's high yield. So please make sure you remember that if you get asked, what is the first line drug for seizures in neonate, your answer should be phenobarbital. Okay. Next one is topiramate. We all know topiramate is used for migraines. We talked about this in the past. So it's mentioned as the same thing over here, valproic acid. It's used for seizures and bipolar disorders. Okay, only try to remember that bipolar disorder, we use valproic acid too. We use valproic acid. Next one is vigabatrin. Vigabatrin is, once again, there's no note. This is just a mnemonic, but we used our own mnemonic, which is bat. Bats are blind, and vigabatrin makes you blind. Are we clear about the anti-epileptic drugs? Are we clear about the anti-epileptic drugs? Yes or no? Okay, does anyone have any confusion? Okay, so did the stories help? Now is it easy to talk about the drugs? Okay, perfect. Perfect. And if you guys do not mind, can I please ask you guys to repeat the names of the drug once again before I move forward? I will tell you guys the mechanism of action, and you can just write the names of the drugs, and I would appreciate it. Okay, so once again, which increases the duration of chloride channel, fast please, barbiturate, drug which increases the frequency of the chloride channel, benzo, drug with the channel, drugs which simply block the sodium channel, carbamazepine and carbamazepine and phenytoin. Okay, drugs has to be extremely lame because they block the voltage gated sodium channel and they block the glutamate, lamotrecine. Okay, Y for lamotrecine, who blocks the voltage gated sodium calcium channel and stops glutamate. Leave. Okay, next one is what a name of the drug that is at the top of the game because they block the sodium channel and they increase GABA, pyramid. Very good. Next one is what is the name of the older brother who kills, who blocks GTA? Who blocks GTA, GABA transaminase, Val blocks it. Okay, the name of the younger brother always has to take him up one notch and kill him. Vigabatrin. Okay, vigabatrin. The drug which works in thalamus. What is the name of thalamus? Ethosuxamide. Okay, very good. The drug works in the thalamus, ethosuxamide. Okay, am I missing out on anything? Oh, okay. There is another drug which is used. I like to call that drug gabapentin. What's the name of the drug? Gabapentin. What's the mechanism of action of gabapentin? Mechanism of action. Calcium channel blocker. Blocks voltage gated calcium channel. And also act as an analog. Okay, good. Very good. Okay. Okay. So now what we will be doing is we would be moving on, and I will keep this picture for later. Okay, I will explain this picture for later because this picture is used for all the mechanism of actions of all the drugs that we have talked about. But since we have already talked about them, okay, I do not want to use this picture anymore. Since we know how the drugs work, okay, I will use this picture at the end of the lecture. Is that okay? Yes or no? Because we have to move forward. We already spent on 1 hour studying seizure drugs, but that 1 hour was not wasted. Why was it not wasted? Is not only did we study the drugs, we are successful in remembering the drugs itself. Okay, so that's that. Can we take a break? Okay, do you guys want to take a break now or just after we read a couple of more pages? Okay, can we just read at least 1 or 2 more pages? Okay, then we can take the break. Okay, because we want to finish pharmacology by at least today. Okay, so that's that. Okay, next one is so the first drug that I want to talk about once again is barbiturate, and we know the mechanism of action of barbiturates. So I'm not going to go into any more details. Okay, the examples of barbiturates are phenobarbital, pentobarbital, thiopental, and seclobarbital. Okay, out of all of this, which one of these drugs are the shortest acting? Shortest acting. Which one of the benzodiazepines are the shortest acting? Very good. This is thiopental sodium. Okay, very good. Okay, and where do we clinically use them? We use them for anxiety, we use them for seizures, we use them for insomnia, and the important one is it's used for the induction of anesthesia, and that's important, that's high yield. Okay, So, okay. So it's used for the induction of anesthesia, thiopentosodium, which is a barbiturate. Once again, barbiturate meaning barbiturate, durate meaning they increase the duration of the GABA ion channel. And we also talked about the adverse effects already. Okay, they cause severe cardiorespiratory depression, cytochrome P450 inducer. Okay, and there's another thing is they should be inhibited in porphyria. Okay, they should be inhibited in porphyria. Why is barbiturate inhibited in porphyria? Does anyone know? Why is barbiturate? Does anyone know why we do not use barbiturate in porphyria? Very good. Okay, very good. What they do to alpha amino levulinic acid synthase? Right. They try to increase the porphyrin. Okay, they try to increase the porphyrin. Did I talk about this before? No? Okay, I felt like I talked about this before. Okay. Okay, so if I didn't, then we're talking about it right now. Okay, so alpha amino levulinic acid is involved in the porphyrin production, and as a result, barbiturate are contraindicated in porphyria. Okay, so remember that. Next group of drug I want to talk about is benzodiazepine. Benzodiazepine, what they do is, first of all, what are the examples? The examples are easy to understand. High yields are diazepam, lorazepam, okay, oxazepam. Then we have midazolam. This one, chlordiazepoxide. Okay, so let me tell you something interesting. The interesting thing is, Usmle knows that you know the names of benzodiazepines by PAMs. Diazepam, lorazepam, then temazepam. Then if you see a drug which is called triazolam, okay, you know it's a benzodiazepine. But they will have certain questions where they will try to confuse you by mentioning chlordiazepoxide, okay, and they will try to confuse you with hydrochlorothiazide. Hydrochlorothiazide. What is hydrochlorothiazide? What is hydrochlorothiazide? Fast answers, please. Exactly, it's a diuretic. And the thing is, you will get a lot of questions regarding diuretics, okay? And they will have chlordiazepoxide in the answer stem, and you would think chlordiazepoxide is a one sort of hydrochlorothiazide, okay? So chlordiazepoxide, chlordiaz, okay? Focus on diaz, okay? Diaz, focus on diaz, and chlordiazepoxide is a benzodiazepine, okay? It's a benzodiazepine. That's what chlordiazepoxide is. Okay. So do not confuse chlordiazepoxide with chlorothiazide. Okay. Very common mistakes made by a lot of students. Okay. Next one. Next one is, what is the mechanism of action? The mechanism of action, we talked about this. They increase the frequency of the chloride channel. Okay. And we have to remember this mnemonic over here. That is ATOM. ATOM stands for alprazolam, triazolam, oxazepam, and midazolam. Why? Because these are the short acting ones. Okay, they are the short acting drugs. Okay, so once again, alprazolam, triazolam, oxazepam, and midazolam. So these are the four drugs that are short acting, and they are known as atoms because atoms are small and they are short acting and they have a higher addictive potential, so the people can get addicted to them. Okay, so we have to keep in mind about our atoms. Okay, next one. Next one is, what is the clinical use? Once again, it's used for inducing sleep, used in anxiety, panic disorders, spasticity, okay, general anesthesia, and lorazepam, oxazepam, and temazepam can be used for those with liver disease who drink a lot. Okay, so if you have a patient who comes to your emergency department and the patient has having an have you guys ever seen a patient with alcoholic rage? Anyone? Have you ever seen a patient or a person with alcoholic rage? Okay. Anyone else? Do we have any students over here who went outside to party and where drinking was involved, and you will always have some guy who gets out of control and starts fighting with other people because they got too drunk. Okay, that guy over there is having an alcoholic rage. Okay, that guy over there is having an alcoholic rage. If you have a patient who is having alcoholic rage and if you want to calm them down, okay, the drugs that are used in ERs or emergency departments are lorazepam. Okay, and this is an MBOS question. This is a question from AMBOS. Okay, what is the question from AMBOS? The question from AMBOS is, you have a patient who has come to your emergency department at extreme alcohol with extreme rage, with a past history of drinking alcohol. Okay, and what is the drug you will administer to calm the patient down? Okay, or to put the patient to sleep? The drugs that you will use is intramuscular lorazepam, and after you use the drug, you have to monitor the patients. What do you have to monitor after you calm the patient down? What do you have to monitor? Let's see who is enough to answer this question. Respiratory rate. Okay, respiratory rate. So every one of us are smart to understand that when you administer lorazepam to a patient who has been abusing alcohol, you have to monitor the respiratory rate because that patient can go into respiratory depression. Okay, if the patient goes to respiratory depression, then we have to resuscitate the patient. That's another thing. Okay, but the drugs that is used is lorazepam. Okay, next. What are the adverse effects? The adverse effects are dependence. Once again, CNS depression with alcohol and barbiturates, but they have a less risk of respiratory depression and coma than barbiturate does. Okay. Okay, and the drugs that can be used to treat the overdose, we know a lot of it's also a suicidal drug. If we have any patients with suicidal ideation, they will try to commit suicide by ingesting sedatives. Okay, so the drugs they commonly would like to use is benzodiazepine. And if we have any patient with such sorts, the drugs that can be used to treat the overdose is flumazenil. Okay, flumazenil. And this drug over here is a competitive antagonist at GBA. Okay, so even before benzodiazepine can go and bind, even before benzodiazepine can go and bind to the GBA, flumazenil goes and binds to the GBA. So benzodiazepine cannot go and bind to the so benzodiazepine cannot go and bind to the GBA. So benzodiazepine is upset because flumazenil goes and binds to the GBA. Okay, are we clear? Are we clear? Okay, good. Next one is non-benzodiazepine hypnotics. Okay, or as we would like to call it, the new age sedatives. Okay, the new age drugs. These are comparatively very new drugs. Okay, the new drugs are all Z's. Okay, okay, okay. And how do we remember this? Have you guys seen comic books in which they try to represent a person who's sleeping? Okay, let's say this person is sleeping over here. Okay, this person is sleeping over here, and then you have this Z's on top of the head. Okay, and this gives the ideation, right? This gives you the ideation that this patient or everyone is a patient. I mean, this cartoon is sleeping. Okay, so the drugs that are used for non-benzodiazepine hypnotics, or the drugs that are made, are all your Z's. What are the Z's? Z's for zolpidem, zaleplon, and ezopiclon. Zolpidem, zaleplon, ezopiclon. Okay, so that's the one. How do they act? They act by the same mechanism of action, more or less, by the benzodiazepines. Okay, but the thing is, they act via the BZ1 subtype of GABA receptor. So the GABA receptors have a lot of subtypes. Okay, and they act via the BZ1 subtype. So BZ, everything is a Z for the non-benzodiazepine hypnotic. So all the Z's are zaleplon, zolpidem, and ezopiclon, and they work at the BZ1 subtype of the GABA receptor. Okay, and once again, if someone tries to overdose, we can use flumazenil over here. Okay, they can come and block the GABA receptor. So that's that. Where do we use them? This is normally used for people who are suffering from insomnia. Okay, insomnia, absolute lack of sleep. That's that. And what are the adverse effects? The adverse effects are very easy to understand. They can cause headache, confusion, ataxia. None that is very highly tested in the exam. So that's that. Okay, always remember that the adverse effects, which are very particular to a drug, are more tested. For example, out of all these adverse effects, the drugs, the side effects, which are very particular to a single drug, they are more commonly tested. For example, they will ask you if you know you have, I mean, they would like to know if your knowledge regarding the fact that agranulocytosis is associated with carbamazepine. SGS is associated with carbamazepine. Then hemophagocytic lymphohistiocytosis is associated with lamotrigine, because they are very particular. Okay, they won't ask you which drug causes Stevens-Johnson syndrome, because every anti-epileptic drug more or less causes Stevens-Johnson syndrome. If they ask you that drug, if they ask you which drug is causing Stevens-Johnson syndrome, they will try to see whether you can differentiate your knowledge about anti-seizure drugs and drugs from another group of categories. Okay, so always remember that when you have to read side effects, the side effects which are more particular or more unique to the drug, that is more important. Okay, so ataxia, insomnia, confusion, these are very general side effects. Okay, they are not that high yield. Okay, and that's that. Okay, another one is they have decreased amount of dependence. So if anyone has a tendency to get dependent on benzodiazepine, they can get switched to non-benzodiazepine. So there has not been any question regarding this, but I have a gut feeling they might ask a question regarding this. So if you want, you can put a star behind this. I mean, after this. Okay, next one. Are we clear about benzobarbiturate and all our Z's? Okay. Okay, good. Okay. So isn't this better than looking at picture mnemonics? Because picture mnemonics, you have to memorize the pictures too. Okay, but this way of studying is much easier, much better. Okay, but do not worry, we will subscribe to Physio, where we will use picture mnemonics for absolutely difficult drugs. For all the hard drugs which we cannot make stories about, we will use picture mnemonics. Okay. Next one is suvorexant. Suvorexant. Okay, so what is suvorexant? Okay. First of all, if you have a patient with narcolepsy, which substance is increased in the CSF? If you have a patient with narcolepsy, which substance is used in the CSF? Anyone? Okay, so the thing is, suvorexant is an orexin receptor antagonist. Okay, so it does not let orexin work. Where do we use them? We use them in insomnia. Okay, suvorexant is used in insomnia. So the most important thing to remember about suvorexant is the mechanism of action of suvorexant, which is it's an orexin receptor antagonist. Okay, orexin receptor antagonist. And what are the adverse effects? The adverse effects are basically CNS depression, okay, headache. Then the patients have abnormal sleep related activities. Okay, contraindication. For the contraindications, we cannot use them in narcolepsy. Why? Because in narcolepsy, orexin is already increased. Okay, so we do not want to increase the orexin more by making suvorexin act as an antagonist. Okay, they are not recommended in patients with liver disease and limited physical dependency or abuse potential. Not high yield. Not high yield. The most important high yield is the mechanism of action. Okay, orexin receptor antagonist. That's it. And where do we use them? We use them in insomnia. Next one is rameltian. Rameltian, and rameltian has the word melty. Melty helps me remember that it's a melatonin receptor agonist. Okay, melatonin. Okay, which nucleus is of the hypothalamus is involved for melatonin? Which nucleus is responsible for melatonin? Get some fast answers, please. Question. Okay, what was your question? Orexin increases or decreases? Okay, so in narcolepsy, what happens is, first of all, what is narcolepsy? First of all, what is narcolepsy? First of all, what is narcolepsy? Day sleep and fall. Okay, day sleep and fall. So the thing is, okay, so the thing is, we have this one group of proteins. Okay, we have this one group of protein which are known as orexins. Orexins are basically synthesized, okay, by lateral hypothalamus. Okay, and what this does is this orexin is responsible for helping us fall to sleep. Okay, so in patients with narcolepsy, the orexin is decreased in the CSF. So if we have to answer your question, Dr. Iman, if orexin increases or decreases, then in patients with narcolepsy, there is a decrease in orexin containing um, neurons in the brain. Okay, are we clear? Does anyone have any more question? What is your question? What is your question before we move on, please? Okay, so if you have any question, please keep your question in mind and please ask me when I ask you guys again. If not, then I would like to move on. Okay, next one. Next one, the drug that I was talking about was Rameltian. Okay, so once again, Rameltian it regulates melatonin. And which nucleus of the hypothalamus is responsible for melatonin? Can I get some fast, please? Can I get answers? Suprachiasmatic, very good. Okay, so that's what it is, suprachiasmatic nucleus. So that's where it is. It binds to the MT1 and MT2 in suprachiasmatic nucleus of the hypothalamus. And what is melatonin used for? Melatonin is used to induce sleep, and basically melatonin is secreted from our brain. Okay, so basically, if you have a patient who is waking up early in the morning and who is seeing the sunlight, okay, their suprachiasmatic nucleus will work accordingly, meaning that when it will be nighttime, the suprachiasmatic nucleus will get activated and melatonin will get secreted, and patients will see that the absence of light is making them fall asleep or drowsy. Okay, so that's that. Research was conducted in which they did a research in a couple of patients in which they wanted to see if melatonin is increased or decreased in response to light. So what they found was they concluded the research. Okay, the results were not confirmatory, but they concluded the research saying that the absence or presence of light affects the secretion of melatonin, meaning that if you have a person inside a cell who is completely void of light, okay, who cannot see whether it's daytime or nighttime, okay, their melatonin secretion will not be the same as your melatonin secretion. Okay, you who can see the sunlight or like sees the evening or the night, your melatonin secretion is not the same as the person who does not see the light or the sunlight or the night. That's what it is. Okay, so melatonin secretion, okay, although it does not say it over here, you might get some questions in MBOS where they want to know whether you are acquainted with the fact that melatonin secretion is associated with changes in daylights. Okay, so melatonin secretion is associated with changes in daylights. Okay, this was taken from Firecracker. Okay, so we took this information from Firecracker. Next one. Next one is triptans. What are triptans? Okay, where do we use triptans? Fast answers, please. Where do we use triptans? Can I get some fast answers? Migraine. Okay, very good. So we use triptans for migraines. Okay, and how does triptan work? We talked about this in the past. How does triptan work? Triptans. Can I get some fast answers, yes or no? If no, then I will move forward. Do you guys know how triptan? Okay, so basically what triptan does is it's a serotonin agonist. Okay, so what does it do? It inhibits the action of vasoactive peptide release. So it does not cause vasoconstriction directly. It causes vasoconstriction indirectly. It induces vasoconstriction by preventing the release of vasodilatory substances. Okay, and we use them for migraine, of course, but do you remember how I told you guys that we cannot use triptans for patients with coronary artery disease because they can cause vasospastic angina or Prinzmental angina, okay, because they can cause coronary artery vasospasm. Okay, so triptans, The only question you will get is from the mechanism of action. And what is the mechanism of action of triptan? They inhibit the release of vasoactive substances. They inhibit the release of vasoactive substances. Okay. With that being said, we are done with all the anti-seizure and anti-epileptic drugs. Okay. Anti-seizure and anti-epileptic drugs. Do we have any question? Do we have any question? Okay, have you guys understood all the drugs? First of all, let me ask you guys, okay? First one is Ramelpian. How does it work? What is the mechanism of action of Ramelpian? No. Okay, important drugs. Then the next one, what is the mechanism of action of what is the mechanism of action of triptans? Please. What is the mechanism of action of non-benzodiazepine hypnotics? Okay. Okay, good. So now, if you guys want, we can take a break. Do you guys want to take a break now? Is move on to the Parkinson? Yes. Okay. So we can take a break for 10 minutes, and then after that we can come back. Okay. Okay. Thank you for putting your time and attention. Okay. And we will be back in 10 minutes. Okay, is everyone back from their break? Do we have everyone who's back from their break? Okay. Is everyone back? Okay, so what do you guys usually do during your break time for 10 minutes? What do you guys usually do for your break time in 10 minutes? Do you guys scroll through Facebook, Instagram, or drink coffee or grab something to eat? Okay, coffee, yes. Once again, coffee is the best friend of any medical student or a physician. So good, good. Smoothie, okay. Lecture 19, okay. I will try to provide you lecture 19. Okay, very good. Okay. Okay, so tomorrow is the weekend. Do you guys have any plans with your friends and family for the weekend? Yes or no? You guys should plans for the weekend, okay? Because every weekend should be celebrated. Okay, you guys work absolutely very hard during the whole week, and you need to take at least one day off in your weekend to get away from everything so that you can get your mind straight and you can um, focus on the next week better. Okay, so as I always say, work hard, play hard. Okay, if you guys work hard, make sure to have fun harder than you work. Okay. Okay, revise CNS and family meeting. Okay, good. Okay, if you guys want to sacrifice your good times and study, okay, that's very admirable. Okay, but I would advise you guys to take one day off at least so that you guys can focus more, okay, from next week onwards. Having said that, hoping everyone is back. Since everyone is back, let's start with our second group of lectures. Okay, for this one, what we would be doing is we would be focusing on anti-Parkinsonism drugs. Okay, we will be focusing on anti-Parkinsonism drugs. Okay, 1 second, let me just share my screen. Okay, okay, okay. Can you guys see my right now? Can you guys see my screen? Yes or no? Okay, good. So we will start talking about the anti-Parkinsonism drug, and what we would be doing is we would be starting with a diagram. Okay, and hopefully after the end of our diagram, we would be done with our knowledge. I mean, our study and learning about the anti-Parkinsonism drugs. Okay, so first thing that I'm going to draw over here is, first of all, what I would like to know is in Parkinsonism, which neurotransmitter is deficient? Can I get you guys to unmute yourself and answer because this will help me complete the drawing. Okay, if you have to answer, please unmute yourself and give me the answer. Okay, which neurotransmitter is deficient mostly in Parkinsonism?
Dopamine.
Which
Dopamine.
neurotransmitter? Dopamine. Very good. Okay, dopamine is absent. So our goal is that we have to get dopamine inside the brain. Okay, that is our goal. What is our goal? Our goal is dopamine has to go in the brain. Okay, so what's happening is at first, this thing that I drew over here, this thing that I drew over here is our blood brain barrier. Okay, this thing is our blood brain barrier. Okay, and we talked about the blood brain barriers. Can I please ask you guys if you remember what are the three components of blood brain barriers? Fast answers, please.
The basement membrane of endothelium, then
And
endothelium,
and
then the terminal feet of astrocyte.
very good. So terminal feet of astrocyte, non-fenestrated capillary endotheliums, and basement membrane. So this is the blood-brain barrier, which is preventing the substances in the blood from entering the brain. Okay. So first of all, this is the blood-brain barrier. This is the next thing that I'm going to draw over here. Okay. This next thing I'm going to draw over here is the neuronal is the end of a neuron. Okay. And this is the synaptic space, and this is our brain dopamine receptor. Okay, I will use a different color. This is our brain dopamine receptor. Okay. Okay, so the first thing that I want to talk about is our goal is we have to get dopamine inside the brain. Okay, so our drug is dopamine, or as we would like to call it, L-dopa. What is the full form of L-dopa?
Levodopa.
Very good. Okay, so levodopa has to go, and levodopa will, what will levodopa do? Since they are lipid soluble, okay, they will enter the blood-brain barrier, okay, by simple diffusion. After they enter the blood-brain barrier, they will be taken up inside the neurons, and inside the neurons, the levodopa, what they will do is they would convert to, what they will do is they will convert to dopamine. Okay, dopamine, and this dopamine gets stored inside neurosecretory vesicles. Okay, these dopamine is inserted into the neurosecretory vesicles, and then the next thing, what happens is the neurosecretory vesicles, what they will do is the neurosecretory vesicles, they will fuse with the neuronal end, and they will release the dopamine. Okay, so they will release the dopamine. So this dopamine will be released into the synaptic space. After the dopamine is released into the synaptic space, these dopamines, what they will do is they will go and easily they will bind to the dopamine receptors. Okay, they will go and bind to the dopamine receptors, and then dopamine comes and dopamine binds over here. Okay, after dopamine binds, then we have our goal reached. Okay, we have the goal reached. Now this is how a normal patient looks like. This is the whole process of a normal patient. I mean, in patients like me and you who do not have Parkinsonisms, this is how our mechanism is. Our levodopa is crossing the blood-brain barrier, entering the neurons, then entering the neurosecretory vesicles. Fusion happens, then they get released in the synaptic space, and with the post-synaptic membrane dopamine receptor, they bind, and then they cause the mechanism of action. But in a patient with Parkinsonism, okay, this dopamine is already not there. Okay, so this dopamine is already not there. So what we do is we try to give the patients levodopa. What we try to do is we give the patients levodopa. Okay, and do we give levodopa by itself, or do we use another drug? Fast answers, please. Do we give levodopa by itself?
We use another drugs.
What is the name of the another drug that we use?
Peripheral decarboxylase inhibitors and COMT inhibitors.
Yeah.
Okay, what is the name of those drugs, please?
Entacapone, siligilene.
Okay, so first and foremost, the first drug that we give with levodopa is a simple drug called carbidopa. Okay, so what happens is this levodopa over here, this can get broken down, okay, out in the blood. First, we will talk about the breakdowns in the blood. In the blood, they can be broken down by two mechanisms. One is by dopa decarboxylase. Another one is by COMT. COMT stands for catechol-orthomethyl transferase. Catechol-orthomethyl transferase. Okay, so this can get broken down in two ways. So what is our goal? Our goal is to block. Okay, what is our goal? Our goal is we have to block these two enzymes. We have to block dopa decarboxylase. Okay, we have to block dopa decarboxylase, and we also have to block catechol-orthomethyl transferase. And the drug that is used to block dopa decarboxylase, is, so what is the name of the drug that blocks dopa decarboxylase? Very good. The name of the drug is carbidopa. Okay. Okay, the name of the drug is carbidopa. And the drug that blocks COMT, or catechol-orthomethyl transferase, outside over here in the bloodstream, this drug is known as, have you guys heard of Al Capone? Al Capone? Okay, who is Al Capone? Do you guys have any idea who this guy is?
No.
Yes or no? Anyone? Do we have any American students over here? Any Americans? Any American? Okay, the reason is because this guy is a very famous American gangster. A lot of movies have been made about him in the past. Okay, so this fat guy over here, okay, he looks extremely harmless, but he is very harmful. Okay, so COMT, catechol-orthomethyl transferase, is a very major way they can go and block the levodopa, and the gangster drug that is used to block this enzyme, okay, that gangster drug is Al Capone, meaning tall Capone, okay, or Antacapone, okay, tall Capone or Antacapone, okay. Okay, it really surprises me. We have no student over here who knows Al Capone. Anyone?
No.
Okay, okay. So no student over here knows who Al Capone is. Okay, so do we have any American students over here? Do we have any students over here from America? Anyone? Okay, and you guys have never heard of Al Capone. Okay, no problem. If you guys have not heard about Al Capone, okay, now you guys know. If you guys want, if anyone has Netflix, you guys can go and watch movies about him. Okay, there are a lot of documentaries. Okay, good. Next, so we are done with this stage. Okay, now if we block these two enzymes, the levodopa can now enter the neurons. Okay, once the levodopa entered the neurons, over here inside the neurons, this levodopa can get broken down again. Okay, this levodopa, I mean, which gets converted. Okay, so once the levodopa enters, first of all, once the levodopa enters, then dopamine decarboxylase. Okay, dopamine decarboxylase converts the levodopa to dopamine. Okay, so we do not want to block dopamine decarboxylase inside the neuron. Okay, that's why I used black meaning that it's working. Okay, but this dopamine over here can get broken down once again by COMT and another group of enzymes, that is MAO. MAO stands for monoamine oxidase. Okay, monoamine oxidase. So once again, do we have to block these enzymes? Yes or no? Yes or no? Do we have to block these enzymes?
Yes.
Yes or no, please?
Yes.
Yes.
Okay, good. So once again, COT, the gangster drug. Okay, what are the names of the gangster drugs?
Alcohol.
Tolcapone and Antacapone. Very good. Okay, Tolcapone and Antacapone. And another drug is monoamine oxidase, and we have to block monoamine oxidase. And the drugs which are used to block monoamine oxidase are
Selegiline.
very good.
Selegiline.
Selegiline and
Versatility.
Racegiline. Very good. Okay.
Racegiline.
Very good. Okay, so we have we have selegiline and then we have racegiline. Okay, so after we prevent the breakdown of the dopamine obviously enters over here. Okay, and then once the dopamine gets released over here, what this dopamine does is this dopamine, they have a tendency of being reuptaken. Okay, they have a tendency of being reuptaken. Okay, so do we have to block this reuptake to increase the dopamine over here? Yes or no?
Yes.
Okay, so dopamine, so we can also use some dopamine reuptake inhibitors. Okay, we can also use the dopamine reuptake inhibitors, and the dopamine reuptake inhibitors that we can use. Okay, so the drugs, the name of the drugs is also, they don't say over here, not as much in first aid. Okay, but the drug that is amantadine. This drug amantadine, this increases the availability of the dopamine. This increases the availability of the dopamine either by working as a reuptake inhibitor, or straight away they increase the presence of more dopamine in the synaptic cleft. Okay, have we understood? Yes or no? Yes or no?
Yes.
Okay, good.
Yes.
Okay, good, very good. Then we have another group of drugs. Okay, so these drugs, what they do is, this is that group of drugs. These drugs, what they do is they go and directly activate the dopamine receptor. Let's say you do not have enough dopamine, but these drugs, they act as dopamine agonists, and these drugs, they go and they block and they activate the dopamine receptors. And these drugs, the name of these drugs are very easy to understand because they are very widely used. First one is bromocriptine. Very good. Next one is
Pramipexole,
pramipexole.
pronitibrol,
Next one, ropinirole. Out of all of these three, okay, pramipexole and ropinirole, these are non-opioids. argot. Okay, they are not argot containing drugs. They are non-argot, and bromocriptine is argot. Okay, they are argot. Okay, good. Okay, so what I will do is, can I give you guys exactly 10 seconds? I will give you guys 10 seconds, and then I will need one of you guys to explain the whole thing. Okay, if anyone is ready, please tell me you're ready, and then we can start. Excuse me? Do we have a question? Okay, no question. Okay. Is anyone ready to explain the diagram? Is anyone ready to explain the diagram? Fast answers, please. We do not have a lot of time. We want to finish the pharmacology section today. Yes or no? Yes or no? Do we have anyone who can only tell me the names of the drugs? That's it, nothing else.
Yes.
Okay, good. Thank you. Okay. Okay, good. First of all, if we have dopamine in the blood and dopamine gets broken down by two enzymes, what are the names of those enzymes? Please don't look at your book.
Dopa decarboxylase
And
COMT.
COMT. Very good. So what is the drug that is used to block dopa decarboxylase?
Carbidopa.
Very good. What is the name of the gangster drug that is used to block COMT?
Cholcapron.
Capone and entacapone, like our gangster over here, the American gangster, Al Capone. Okay, good. After the levodopa enters into the into the brain, into the neurons, okay, and they get converted to dopamine by dopa decarboxylase. That dopamine can get broken down by two more enzymes. What are the names of those enzymes?
Monoamine oxidase.
Monoamine oxidase and
COMT.
COMT. Very good. And what is the name of the drug that blocks COMT?
The gang.
The gangster drug. Very good. Tolcapone and entacapone. And what are the names of the drugs that blocks monoamine oxidase?
Selagine and
Very good. Selagine and racegine. Very good. Okay. Why do we have only participation from one physician? Why is not everyone else trying to participate? Are you guys not clear? Okay. Next one is after the drug enters the neurocirculatory vesicles, they are released. Once they are released, which drug is used to prevent the reuptake?
to prevent the reuptake.
Amantadine.
Amantadine. Very good. Thank you so much for helping me out. Amantadine. Okay. And after that, the drug goes and binds to the dopamine receptor. What is the name of the dopamine agonist?
Bromocriptine.
Bromocriptine and
Bromocriptine, bromipixol,
Okay, thank you so much. Okay, see, even since you guys were not talking, even if you guys were not talking, a little baby was there who was saying bromocriptine. Okay, so the little baby is better than you guys. Okay, so give my love and prayers to the little baby who said bromocriptine. Okay, next one. Okay, so we are done with Parkinson. Okay, so we're done with the Parkinsonism. Okay, next one is, now let's start with our text over here. Okay, so what is the Parkinsonism disease therapy? The Parkinsonism, first of all, is due to the loss of the dopaminergic neurons. Okay, and we already know about this because we asked you guys which neurotransmitter is absent, and the absent one is dopamine. Is dopamine. Okay, next one is dopamine agonists. We already talked about this. The dopamine agonists are argot and non-argot, and non-argot are the ones which we prefer because argots are not used. They can cause a lot of problems, for example, DVTs and this and that. Okay, so we try to use non-argot components such as pramipexole and ropinirole. Okay, and the question from over here is, okay, you will get a question about this from UWorld over here is you have a patient, Parkinsonism patient, after he ingested a drug. This resulted in personality change, and the patient started having gambling or other types of addictive types of behaviors. Okay, and what is the drug that can cause this type of behavior? The drugs that can cause these types of unhealthy addictive behaviors are the dopamine agonists, that is pramipexole and ropinirole. Okay, pramipexole and ropinirole, that's what it is. So postural hypertension and hallucinations, okay, these are also used, but the drugs that can cause addictive types of actions are the dopamine agonists. Another side effect that is important is postural hypertension. Okay, if they ask you a question about a patient who is undergoing Parkinsonism treatment, after ingestion of a drug, they had postural hypertension. That's because in postural hypertension there is peripheral pooling of the blood. As a result, the patients get postural hypertension when they stand up. Okay, so the drug that causes this is pramipexole and ropinirole. Very good. Okay, good. We are done with all of this. Next one is increasing the dopamine availability. What are the drugs that increase dopamine availability? The drugs are amantadine, okay, and as I have said before, that it decreases the reuptake of dopamine by this mechanism. Another one is it also increases the release of dopamine. Okay, so that's that. So the drug which makes dopamine available is amantadine. So A for availability, A for amantadine. Okay, and what are the side effects? The side effects are peripheral edema, livedo reticularis. Okay, they're not that high yield. Okay, but livedo reticularis is high yield in that sense that you have one question about this in UWorld, about one drug which can cause livedo reticularis. Now we have to know what livedo reticularis is. Okay, what is livedo reticularis? Okay, this is how a patient with livedo reticularis looks like. It's a dermatological condition. Okay, and the drug which can cause livedo reticularis is amantadine. Okay, next one is increasing in levodopa availability. Okay, so in the drugs which increase levodopa availability are levodopa itself. So we use levodopa. Okay, these are agents that can enter through the blood-brain barrier, but they have to be given with carbidopa to prevent peripheral levodopa degradation. If we do not give carbidopa, then there will not be enough levodopa to go inside the brain. So we have to give it with carbidopa to prevent peripheral levodopa breakdown. Okay, now my question is, can carbidopa cross the blood-brain barrier? Yes or no? Can carbidopa cross the blood-brain barrier? No? Obviously. If the carbidopa could cross the blood-brain barrier, then levodopa would not have been converted to dopamine. Okay, so keep that in mind. If they ask you which drug cannot cross the blood-brain barrier, it's carbidopa. Okay, so levodopa is broken down by carbidopa. The carbidopa prevents the breakdown of levodopa, so levodopa enters. Once it enters, we have another gangster drugs, that is tolcapone and entacapone. They prevent the COMT inhibitors. Okay, so COMT inhibitors are tolcapone and entacapone, and they prevent the breakdown of levodopa by COMT to 3-O-methyl-dopa. 3-O-methyl-dopa. Okay, that's that. Okay, now once they enter the neuron, then another group of drugs I talked about along with COMT was MAO, was monoamine oxidase inhibitors, and the drugs are selegiline and rosugeline, and they prevent the breakdown by monoamine oxidase. Okay, so if they break down monoamine oxidase, they can result in the formation of DOPAC. Okay, and DOPAC is not dopamine. Okay, it's a breakdown form of dopamine, so we have to prevent this. In order for that, we have to give selegiline and rasagiline, which breaks down the monoamine drugs. Okay, next ones are your carb excess cholinergic activity. I mean, the drugs which can increase cholinergic the drugs which can cause decreased cholinergic activity. Okay, what are the drugs? The drugs are benztropine, trihexyphenidyl. That's not important. Benztropine is important. Okay, only benztropine is important because it's an anti-muscarinic drug and it improves the tremor and rigidity. Because acetylcholine can go and cause excessive tremor and rigidity. This is prevented by giving anti-muscarinics or benztropine. Okay, now my question is, first of all, Fast and I need I'm going to ask fast questions and I would need excessive fast answers so that we can move on. Okay. First of all is okay. What is the dopamine agent that we use to increase dopamine inside the brain? Fast answers, please. Well, what is the dopamine agent that we use to increase the dopamine inside the brain? Levodopa. Fast answers, please. Levodopa. Okay. Which drug do we use alongside levodopa to prevent the peripheral degradation? Carbidopa. Very good. Okay. Use to prevent the degradation by COMT. What is the name of the drug that prevents the act COMT? Tolcapone and entacapone. Okay. Next is after the levodopa, it enters inside the neuron. It can get broken down by COMT once again, and we use tolcapone and entacapone. We said that. What are you block MAO? The drugs that are block MAO. Racetylene. Okay. The drug prevents dopamine intake and increases dopamine availability. And what are used as dopamine agonists? Drugs that are used as dopamine agonists. Morphine and what are the argot and non-argot drugs? Oh, okay, good. So is your voice or is the voice breaking? Is the voice breaking or guys? Voice breaking? Is it better now? Break once again. Okay, so can you guys hear my voice now? Is the voice better? Okay, good. Okay, good. Okay. So have you guys understood the Parkinsonism drugs? Okay, good. So let's move on. Okay, next one is, so they have a little more information on levodopa and carbidopa. Okay, the information on levodopa and carbidopa is basically we use this as a combination, that is carbidopa levodopa combination. That is we want to prevent the peripheral degradation by dopamine decarboxylase. So we give carbidopa with levodopa. What this does is this increases the dopamine inside the brain, and unlike dopamine, levodopa can cross the blood-brain barrier. Okay, so they are converted by dopa decarboxylase in the CNS. There is nothing new to which we have already studied. So that's that. We have already said this. Carbidopa is a peripheral dopa DDC inhibitor, and we have already mentioned this. So there's nothing new over here. So we know the mechanism of action. Where do we use them? It's a very obvious question. And the obvious answer is Parkinsonism. We already know this. Okay. Now the adverse effect. Okay. The adverse effect is, okay, the adverse effects with levodopa, carbidopa are the ones which we talked about, that they can cause postural hypertension, gambling, uh, uh, um, addictive types of behaviors such as gambling, okay, alcohol, and this and that, okay. And with progressive disease, levodopa can lead to on and off phenomenon, meaning that there could be mobility, which can be improved during on periods, meaning on periods are the periods in which the patients take levodopa, in which the Parkinsonism can be completely normal, okay? And then once they stop taking the levodopa, the patients have, once they stop taking the levodopa on untimely basis against the doctor's advice, if they do that, well, what will happen is that the movement disorders will get worse. And after that, if they want to start levodopa once again, they will respond very poorly. The response to levodopa can be very poor. Once again, what is on and off phenomenon? On and off phenomenon is if a person has Parkinsonism and they are taking levodopa and they have they have a better response to the drug. So their movement disorders have been normalized. Okay, so what they think that if that is normalized, then what they do is they make a mistake of not taking the drugs on time because they think that they are healed. So what happens is they do not know about the on and off phenomenon, that it's just the on phenomenon, meaning that the levodopa is temporarily fixing your problems. But if they stop taking the drugs, what this happens is their movement disorders are back again. And when they want to start the levodopa once again, it does not work like how it did the first time. Okay, so this is known as on and off phenomenon. Okay, are we clear about levodopa, carbidopa? Yes or no? Okay, good. Next one is selegiline and rasagiline. Okay, and they selectively inhibit monoamine oxidase. Okay, they selectively inhibit monoamine oxidase. Okay, and what this does is it increases the dopamine availability in the brain. Okay, this increases the dopamine availability in the brain, and we know that because we talked about the fact how monoamine oxidase is used to degrade the drugs in the neurons, right? So that's what it is. And selegiline selectively inhibits monoamine B and is more commonly found in the brain. Okay, that's that. Okay. So we have already talked about this. There's nothing new that we have to learn from over here. And that is all you have to know about the anti-Parkinsonism drug. Okay. Are we clear? Can we start with the next group of drugs? Okay. Okay, good. Okay, so first of all, what is another name for amyotrophic lateral sclerosis? Amyotrophic lateral sclerosis. What is the name of the drug for, what is the another name for the disease, amyotrophic lateral sclerosis? Fast answers, please. Lou Gehrig's disease. Very good. Thank you so much for your answer. Lou Gehrig's disease. And what is the drug that we use to treat Lou Gehrig's disease? Lou Gehrig's. Relu. Anyone else? Reluzole. Very good. The drug that we use to treat Lou Gehrig's disease is Reluzole. Okay. Next one is I have a, so the next one is I want to talk about my friend. Okay, I want to talk about this friend of mine. So I'm not sure if you guys know her. Okay, I'm not sure if you guys know her. This friend of mine, okay, her name is Benazir. Okay, what's her name? Her name is Benazir. And what is Benazir's problem? Her problem is, okay, she likes to dance. Okay, Benazir likes to dance. Okay, who is Benazir? I have a friend called Benazir. It's a true story. Okay, she likes to dance anywhere and everywhere. Okay, even in front of people she does not know. My friend Benazir wants to dance. Okay, she wants to make involuntary movements. Okay, in which disease do you get these type of involuntary movements? What is the name of the disease in which you get involuntary movements? In which disease do you get chorea? Huntington's disease. Okay, involuntary flinging of the limbs. Okay, so my friend Benazir does not have Huntington's disease, but if you see her, you would believe she has Huntington's disease. Okay, so my friend Benazir, okay, the drug we use to treat Huntington's disease is tetrabenazine. Okay, what is the name of the drug that we use to treat Huntington's disease? Tetrabenazine. Okay, so next time you see my friend Benazir, okay, ask her to take tetrabenazine. Okay, tetrabenazine. Once again, what is the mnemonic for my friend who has? Right. Okay, good. Okay, so tetrabenazine. Okay, so it moves her four limbs. Okay, so the Dr. MS is very smart. Thank you so much, Dr. MS. What Dr. MS said is benazine moves her four limbs for tetra. Okay, so very good, very smart. So tetrabenazine. Okay, very good. Next one. Next one is I have three other friends. Okay, so I have three other friends. Okay, and the name of those friends are Donna, and another friend I have, her name is Riva, and another friend I have, and her name is Mima. Okay, so who are the three friends I have? They are Donna, Riva, and Mima. And the problem with these three friends of mine, okay, the problem with these three friends are they forget everything. Okay, they forget everything when they leave the house. They forget to lock the door. When they leave the car, they forget to close the car. Okay, they leave the keys inside the car, and they just leave. Okay, they forget where they park their car every day, and it's a big problem. So I never really hang out with them because it's an issue because they have severe memory problems. Okay, so what do you think? What do you think? Which disease does my three friends, Donna, Riva, and Mima, have? What is the name of the disease? Alzheimer's. Very good. Okay, so I'm pretty sure each and every one of them have Alzheimer's disease. Okay, depending on how they keep on acting. So the drugs that I want to use for my friends are donepezil. Okay, then rivastigmine, then memantine or memantine. Okay, okay, donepezil, rivastigmine, and memantine. Are we clear on all the names of the drugs? First of all, okay. First of all, what is the drug that is used to treat AML or amyotrophic lateral sclerosis? Fast answers, please. Can I get some fast answers? Riluzole. Okay. Well, what is the drug that is used to treat Huntington's? Huntington's. Fast answers, please. Huntington's disease. Tetrabenazine. Very good. Tetrabenazine. Okay. What about the three drugs that are used to treat Alzheimer's? Three drugs that are used to treat Alzheimer's. Fast answers, please. Donna, Riva, and Gakla. Mima. Right. Okay. So, what are the three drugs that are used? Okay. Memantine, and then fast answers, please. Memantine, and what are the two other drugs that are used to treat Alzheimer's? The name goes with the names of my friends. Yes, donepezil and rivastigmine. Donepezil and rivastigmine. Okay. Okay. So now, the thing is, the thing is, okay. In Alzheimer's disease, do you have increased amount of acetylcholine or decreased amount of acetylcholine? In Alzheimer's disease, do you have increased or decreased acetylcholine? Are you guys sure? Can you guys hear my voice? So is acetylcholine increased or decreased in Alzheimer's disease? I know a lot of students said increased, but I do not know why. Okay, it's decreased. That is the correct answer. It's decreased. It's not increased. Okay, acetylcholine is decreased, and the reason acetylcholine is decreased is the reason why there is decreased amount of neuronal firing in between the neurons of the brains. Okay, so acetylcholine is decreased. So donepezil and rivastigmine, okay, donepezil and rivastigmine, what they do is they are acetylcholine esterase inhibitors. Okay, so if you inhibit acetylcholine esterase, will there be increased acetylcholine or decreased acetylcholine? Increased acetylcholine. Very good. So as a result, will there be improvement of the signs symptoms of Alzheimer's? Yes or no? Yes. Okay, good. Next one is memantine. Okay, next one is memantine. Okay, and acetylcholine, is it a excitatory neurotransmitter or a inhibitory neurotransmitter? Okay, excited, very good. Okay, another group of drugs that are used to prevent excitotoxicity. Okay, another group of drugs are used to prevent excitotoxicity in Alzheimer's disease, because we do not want excessive neuronal firing in Alzheimer's disease, because that can cause more brain damage. Okay, what is another group of excitatory neurotransmitter? Can you guys tell me the name of another group of excitatory neurotransmitter? Glutamine, once again, glutamine, very good. So glutamine is the name of another excitatory neurotransmitter. Okay, and my question is, which receptor is used to secrete glutamate? What is the name of the receptor okay, NMDA. So if we have to decrease excitotoxicity by glutamate, do we have to block NMDA, yes or no? Do we have to block NMDA? Yes, okay. And the drug which blocks NMDA are memantine. Memantine are NMDA receptor antagonists. Memantine are NMDA receptors antagonists. Okay. Okay. Next one is riluzole. Okay. Next one is riluzole. Okay. And what riluzole does is, okay, let's go back to our text right now. So we have talked about all the names of the drugs. We have talked about the donepezil, rifostigmine, memantine, riluzole, tetrabenazine. Okay, tetrabenazine, we talked about how it's used to treat Huntington's disease. And what tetrabenazine does is it inhibits vesicular monoamine transporters, or VMAT. Okay, and if we have decreased amount of inhibition of the vesicular monoamine transporters, okay, so as a result, dopamine will decrease. And okay, and our goal for Huntington's disease is to decrease dopamine, right? Because in Huntington's disease, there's excessive dopaminergic activity, and we want to decrease that. Okay, so it's used to inhibit the vesicular monoamine transporter, VMAT. Okay, we know what is VMAT. Let's say this is the neuron. The VMAT are these vesicles over here, which will go and fuse, and then they will help the release of dopamine, and we do not want that. We want to block that. So we use tetrabenazine, which prevents the formation of the VMAT. Okay, next one is riluzole. Riluzole, once again, it's used to treat AML, and it decreases neuronal glutamate excitotoxicity. It decreases neuronal glutamate excitotoxicity. Okay, are we clear about this? Are we clear about these three drugs? Okay. Okay, so are you guys understanding the lecture for today, or is it tiring and exhausting? Is it easy? How is the lecture? I mean, how's it going? I mean, how do you guys feel? Good? Exhausted? Tired? How? Okay. Does everyone feel the same way? Everyone? Okay, so N for no. Okay, anyone else? And the reason I'm asking this is because the next topic, which we are going to begin, is actually quite big. So if we had to take any break, then this would be the time. Okay, so please let me know. Okay, so we have a question from Dr. MS, who has a confusion regarding the NMDA. Okay, so basically, memantine over here, okay, memantine is used as an NMDA receptor antagonist. which helps prevent excitotoxicity. Okay, so excitotoxicity is okay, so in Alzheimer's disease, what's going on is, first of all, you have decreased amount of acetylcholine, and then you have increased amount of excitatory. I mean, there's an increased chance of excitotoxicity, which can be mediated by calcium. Okay, so that's that. So these are the two pathologies behind Alzheimer's disease. We talked about this when we were studying Alzheimer's. Okay, right? So if there's decreased amount of acetylcholine, if we want to increase acetylcholine, we have to give acetylcholinesterase inhibitors, and this will increase your acetylcholine. And another one is, in order to prevent the excitotoxicity, the neurotransmitter that is glutamate, what glutamate does is glutamate goes and glutamate increases the calcium ion conduction across the cell membrane, and this causes excitotoxicity. So we want to prevent that. So that's why we give memantine to prevent the action of glutamate by blocking NMDA receptor. Okay, are we clear? Are we clear? First of all, increase acetylcholine by giving acetylcholinesterase inhibitor. Second, prevent excitotoxicity, block calcium by giving NMDA receptor antagonists, which will decrease glutamate. Are we clear now? Okay. Do you guys want to break, or do you guys want to continue? Yeah, yes or no? Okay, how many of you guys want to break? Okay, everyone wants to break. Okay, how long do you guys want the break for? 10 minutes? Okay, no, I'll give you guys a break for 5 minutes. Okay, so 5 minutes. Okay, so 5 minutes, and then we will come back. Okay, so can you guys hear my voice? Is everyone back from their break? Is everyone back from their break? Can you guys hear my voice? Okay, good. So are you guys ready to begin the next portion of the pharmacology section of neurology? Yes. Okay. Should we start? Okay, so we are going to start. Okay, we are not going to waste any more time and we are going to start. Okay, next. So the first anesthetics. So now we are going to start reading anesthetics. Okay, and anesthetics are comparatively high yield for your purpose of doing well in USMLE step 1. Okay, anesthetics are basically, first of all, we have to study the principles of anesthesia. In order for a drug to go and enter the central nervous system, the drug has to be extremely lipid soluble. It has to be lipid soluble, or else it will not be able to cross the blood-brain barrier. Okay, so it has to be lipid soluble, and I'm pretty sure you guys know all of that. Okay, so what happens is, there are two things which you have to know as drugs with increased solubility in lipids and drugs with decreased solubility in the blood. Okay, so if we have drugs that are more lipid soluble, will they reach the CNS more or not? Yes or no? If we have drugs that are more lipid soluble, will they reach the CNS more or less? Will they reach the CNS more? Or, okay, good. So if they reach the CNS more, will there be increased potency of the drugs or decreased potency? Will the drug be more potent or less potent? More potent. Very good. If the drug is less soluble in the blood, okay, if the anesthetic is less soluble in the blood, then does that mean the drug can have increased does that mean if a drug is less soluble in blood, does that mean the drug can get easily transported inside the brain? Yes or no? Okay, first of all, in order for you to answer this question, is lipid more soluble in blood or less soluble in blood? More soluble or less soluble? Lipid. Less. Very good. If it is less soluble in blood, would it be able to will the drug be able to cross the blood-brain barrier more or less? More or less? How? More. Yes, the answer is more. If lipid is less soluble in blood, then they can easily cross the blood-brain barrier. Why? It's because lipid is less soluble. So a drug which is less soluble means it's more, its lipid components are more. Okay. So the drugs which are less soluble in the blood, that means their lipid components are more. Okay. Right, and they're not metabolized in the periphery to some extent, right? And in that case, will they reach the CNS more or will they reach the CNS less? More. If they reach the CNS faster, will there be faster induction or slower induction? Faster induction. So the induction time will increase. So they will have rapid induction if the solubility is less, and if it's more lipid soluble, then the potency will increase. Okay, next thing. Next thing which I want to talk about is minimum alveolar concentration. What is minimum alveolar concentration? Does anyone have any idea about minimum alveolar concentrations? Does anyone have any idea about minimum alveolar concentrations? What is minimum alveolar concentrations? This is a very basic general pharmacology knowledge. Okay, minimum alveolar concentration means the 50% of a drug that is used to, okay, that is used to provide the effect. Okay, right. So minimum alveolar concentration means that the amount of drug that is required to prevent 50% of subjects from moving in response to stimulus, Or it can also be said that minimum alveolar concentration is the amount of drug that is used to induce anesthesia. Okay, the minimum amount of drug that is used to induce anesthesia. Are we clear about minimum alveolar concentration? Yes or no? Okay, so that is the minimum alveolar concentration, meaning the minimum amount of drug that is used to induce anesthesia. What are the examples? The examples, for example, nitric oxide has a decreased blood and lipid solubility. Okay, thus they can induce faster. So if anything has decreased blood solubility, they can cross the blood-brain barrier faster, and they can cause a faster induction. But the fact is, for example, nitrous oxide has low lipid solubility too. Okay, so nitric oxide, not only is it less soluble in the blood, it is also less lipid soluble. So meaning that if anything is less lipid soluble, will there be more potency or less potency? Lipid solubility, will there be more potency or less potency? Less potency. So nitric oxide, if it is less lipid soluble, is it less potent or more potent? Is it less potent or more potent? Fast answers, please. It's less potent. And if it is less, if it has a less solubility in blood, will they have, can they enter the CNS faster or slower? Less solubility in blood. They cannot stay in blood for a long period of time. So they can, right, faster, good, very good, faster. So they can enter the CNS faster. And if they enter the CNS faster, what will happen to the induction? Will there be faster induction or slower induction? Fast induction. As a result, if any drug has less blood solubility and more, less blood solubility and less lipid solubility, does that mean faster induction and slower or lower potency? Yes or no? Does that mean the drug have? Yes, good. Okay, good. Okay, less potency mean more immunoglobulin. So for minimum alveolar concentration, the potency has to be increased. Okay, so high potency is needed. Okay. It all depends on how much of the drug is needed to cause the minimum alveolar concentrations. If the drug is less potent, then more drug is needed to cause the minimum alveolar concentration. If it is more potent, then less amount of drug is needed to cause the minimum alveolar concentrations for the anesthesia. Are we clear? Are we clear? Have we understood each other? Okay, good. Once again, less blood solubility. Fast induction or slow induction? Less blood solubility. Fast induction or slow induction? Fast induction. Good. Now, more lipid solubility. More potency or less potency? More potency. Very good. Okay, that's what I wanted you guys to know. Okay, next one. Next one is the next group of drugs that we will talk about is inhaled anesthetics. Inhaled anesthetics. Okay, so what are the inhaled anesthetics? The inhaled anesthetics are halothane and fluorine. Okay, all ends with A and E. Okay, all ends with A and E. A and E stands for isoflurane, sevoflurane, methoxyflurane, enflurane, halothane. Okay, A and E, desflurane. So every inhaled anesthetics are ending in A and E. And the good news about inhaled anesthetics are the mechanism is unknown, so we don't have to study it. Okay, so that's an extremely good news. So we don't have to study the mechanism of action because no one knows the mechanism of action. The mechanism of action is unknown. Okay, so that's that. Okay, and what is the effect of inhaled anesthetic? The inhaled anesthetic, the effect is myocardial depression. Okay, it can also cause respiratory depression. Okay, another one is inhaled anesthetics. They will increase the cerebral blood flow and decrease the cerebral metabolic demand. Okay, they will increase the blood flow and decrease the cerebral metabolic demand. Okay, and this is pretty easy to understand. I'm going to tell you how. Okay, what is the cerebral blood flow dependent on? Cerebral blood flow, PCO2. Okay. If you have anesthetics, will you hypoventilate or hyperventilate? Hypoventilate. If you hypoventilate, will there be increased PCO2 or decreased PCO2? Increased PCO2. If there is increased PCO2, should the cerebral blood flow increase or decrease? Increase. Okay. So now do you understand how inhaled anesthetic can increase cerebral blood flow? Yes or no? Okay. Is it clear? Okay. Okay, good. Next one. Next one is, and next one is, this is extremely important. This is extremely important. What is malignant hyperthermia? What is malignant hyperthermia? Malignant hyperthermia is a rare life-threatening condition in which inhaled anesthetics or succinylcholine. Okay, first of all, did we not talk about malignant hyperthermia before? Did we talk about this? Yes or no? Yes, we talked about this. Please repeat. Okay, repeat is an anesthetic. If it causes hypoventilation, hypoventilation will increase PCO2. If PCO2 is increased, cerebral blood flow will increase. Okay. Okay. No, it's not the same as heat stroke or okay. Heat stroke and malignant hyperthermia are absolutely different things. Heat stroke is something else. Heat stroke is the inability of your body to dissipate heat. Malignant hyperthermia is a life-threatening condition in which inhaled anesthetics or succinylcholine can cause muscular contractions and hyperthermia. And what is the name of the organelle that is responsible for? Oh, you mean the sign symptoms? No, the sign symptoms are not the same either because there is more muscle contraction in malignant hyperthermia. So patients will get spasm. Okay. And the patients who are undergo malignant hyperthermia after inhaled anesthetics are autosomal dominant for a gene. This gene is known as RIR1. This gene is known as RYR1, RYR1. Okay, RYR1 is a ryanodine receptor gene, which causes increased calcium release from sarcoplasmic reticulum. And what is the treatment for this? What is the ryanodine receptor antagonist? What is the ryanodine receptor antagonist? This is a very easy answer. Okay, treatment for this is variously known. The treatment is dantrolene. Very good. Very good. The treatment is dantrolene. Okay, and how many stars should this be given? Okay, I will give this. Okay, how many stars? I will give this 3, 4, 5. Okay, if I could, I would give it 10 stars. This is extremely high yield. Extremely high yield. I promise you, you will receive these questions in your actual exams. In your actual exams, you will receive these type of questions. Okay. Okay. Okay, next one. Next one is, so have we understood malignant hyperthermia? First of all, I want to discuss this once again, considering how high yield this is. First of all, if you have a patient who has undergone anesthesia and now the patient has severe muscular contractions and the patient have increased body temperature of more than 107 degree Fahrenheit, what is the condition of this patient? Fast answers, please. What is the name of the conditions of this patient? Malignant hyperthermia. Okay, what is the drug that is responsible for causing malignant hyperthermia? Fast answers, please. What is the name of the drug that can cause succinylcholine? Very good. Okay. What is the gene that is responsible for causing malignant hyperthermia? RYR gene. As a result, which ion is increased from the sarcoplasmic? Okay. Which ion is responsible for causing malignant hyperthermia? Calcium. Okay. Calcium. And what is the treatment for malignant hyperthermia? Dantrolene. Very good. Okay, dantrolene. Okay, next one. So we just finished discussing about inhaled anesthetics, meaning the anesthetics which are used to cause inhaled anesthetic. Next ones are intravenous anesthetic, the one which we use to induce anesthesia, to maintain anesthesia by the IV route of administrations. Okay, so the first drug that we want to talk about is thiopental, and we already talked about this. Thiopental, is it a benzodiazepine or a barbiturate? Fast answers. Fast answer, please. Thiopental, barbiturate. Okay, so what is the receptor in which thiopental work? GABA receptor. Next one. Next one is midazolam. Okay, next one is midazolam. Is it a benzodiazepine or a barbiturate? Benzodiazepine. Which receptor does it work on? Fast answers, please. GABA receptor. Very good. It works on GABA receptor. Next one is propofol. Okay. Next one is propofol. Propofol also. Propofol, the P in propofol is used. I use this P to help me remember that propofol potentiates GABA, or it increases GABA. Okay, so propofol potentiates or increases GABA. Okay, so that's what it is. Propofol potentiates GABA. Okay, next one is ketamine. Next one is ketamine. If you have increased GABA, obviously GABA is an inhibitor neurotransmitter, and then GABA will cause inhibition of GABA will cause your inhibitions that is needed for anesthesia. Next one is ketamine. Next one is ketamine. Ketamines are NMDA or glutamate receptor antagonists. Okay, if you have more glutamate, will they cause excitatory conditions or inhibitory conditions? More glutamate, excitatory conditions. If you block the glutamate by ketamine, will there be more glutamate or less glutamate? Easy answer and fast answers, please. Okay, less. If there's less glutamate, okay, will the anesthesia be more successful or less successful? More successful. Very good. So that's why we use ketamine. Ketamine is used as an NMDA receptor antagonist. Okay, and this can also cause dissociative anesthesia. Okay, dissociative anesthesia, this can also cause. Okay. So first of all, what we would do is we're done with the mechanism. Okay, now we know the uses. They are all used for anesthesia. Basically, thiopental is used for induction and short surgical procedures. Okay, midazolam can also be used for procedural sedation. For example, endoscopy, we use midazolam at times. Propofol, okay, propofol is used for ICU sedations. Okay, that's that. Next one is thiopental. Thiopental, the notes about thiopental are that they decrease the cerebral blood flow. They're highly lipid soluble, meaning they're very potent, but they decrease the cerebral blood flow. This has nothing to do with partial pressure of carbon dioxide. Okay, they just decrease the cerebral blood flow by themselves. Okay, so that's that. Midazolam, they can cause post-operative respiratory depression. Okay, that's that. And these are not very high yield. If it was, I would have told you. Okay, the highest yield one is ketamine, the one which increases the cerebral blood flow. So basically, there are two things about intravenous anesthesia that you have to focus on. That is cerebral blood flow. That is your ketamine, which increases the cerebral blood flow, and thiopental, which decreases the cerebral blood flow. So that is something which you have to focus on. And I want you guys to write this down over here. Write cerebral blood flow. Write cerebral blood flow in your book. Okay. And then give an arrow for increased and write thiopental, and give an arrow for decreased and write ketamine, because you will receive questions about this in MBOS. Okay. Please let me know if you guys are done. Are you guys done? Writing that done? Okay, good. Okay. Okay. Next is local anesthetics. Okay, next is local anesthetics. And I'm pretty sure you guys know exactly how local anesthesia works. Okay. Can I get some feedbacks? Does anyone know how local anesthesia works? Which channel do they block? Which channel do they block? Sodium. Very good. So they block the sodium channels. Okay. And have you guys ever heard of the fact that you guys can give adrenaline with local anesthesia? Why do we give adrenaline with local anesthesia? or epinephrine? Vasoconstriction. As a result, we know that adrenaline or epinephrine can cause vasoconstriction, and the local anesthesia stays in that local region for a long period of time. Okay, so this prolongs the duration or prolongs the effect of the local anesthesia. Okay. Okay, so having said that, now let's go back and see if we match. Okay, so you guys have said the exact same thing, that local anesthesia, they block the sodium channel. Okay, and this is very high yield. They want you guys to know, they want to know whether you guys know that local anesthesia blocks the sodium channels or not. Okay, and they're most effective in rapidly firing neurons. Okay, they're most effective in rapidly firing neurons. Okay, and another thing is they're given with vasoconstrictors, as we just mentioned. Okay, because why? Because this results in vasoconstrictions, and this allows the drug to stay at the local site for a long period of time, and this increases the duration of action. Okay, so this increases anesthesia. Okay, another one is in infected tissue. Okay, alkaline anesthesias are charged and cannot penetrate. So in infected tissue, okay, if the tissue is infected, okay, then do we have to use more anesthesia or less anesthesia? If the tissue is infected, more anesthesia. Okay, we have to use more anesthesia. Very good. Okay, good. And the next one is order of blockade. Okay, so small fibers are obviously blocked faster than large fibers. We know that. Myelinated fibers can be easily blocked by more than unmyelinated fibers. Why are myelinated fibers more easily blocked than unmyelinated fibers? Let's see if you can use your basic science knowledge. Why are myelinated fibers easier to block than unmyelinated fibers? Okay, first of all, nodes of Ranvier. Very good. Okay, because at myelinated fibers, you have only the sodium conductions occurring at the nodes of Ranvier. Okay, so since sodium conduction occurs only at the nodes of Ranvier, they do not occur throughout the whole segment of the nerve. Okay, so if we can only block the sodium channels at the nodes of Ranvier, if we can only block the sodium channels at the nodes of the Ranvier, then only a smaller, it will be easier to block the anesthesia. Okay, only in nodes. Good, very good. Okay, next one. Next one is, what are the order of loss? Okay, so what are the things and how is the loss occurring? First of all, the first sensation that goes away is pain. Okay, first sensation that you lose is pain. Then you lose temperature. Then you lose touch. Then you lose pressure. So PTTP. So if they ask you about in what order do you lose the sensations are lost in PTTP, meaning pain, temperature, touch, and pressure. Okay, pain, temperature, touch, and pressure. Okay. Okay. Now let's learn about the names of the anesthesia. The names of the anesthesia are lidocaine, mepivacaine, bupivacaine. We all know the names, okay? And out of anesthesias, we have esters and we have amides, okay? And how do you differentiate esters and amides? Amides have 2 eyes. Esters have only 1 eye. Every local anesthesia with only 1 eye is an ester. Every anesthesia with 2 eyes, 2 eye, 1 eye, and the second eye, okay, they are amides. Okay, they are amides. Okay, now adverse effects. Adverse effects are okay. What are the adverse effects? Excuse me. Okay, my apologies. Okay, so what are the adverse effects? Okay, the adverse effects are basically you have CVS toxicity. Okay, so cardiovascular toxicity for bupivacaine, this is extremely high yield. Okay, and then another high yield adverse effect is methemoglobinemia. Methemoglobinemia. Okay, methemoglobinemia, and that occurs due to benzocaine. Okay, due to formation of methemoglobins. So 2 high yield. One is cardiovascular toxicity by bupivacaine, and methemoglobinemia that is caused by benzocaine. Okay, that is caused by benzocaine. Okay, are you guys okay? I'm not getting a lot of response from you guys. Are you guys exhausted, tired? How do you guys feel? Is this lecture putting a lot of pressure? Are you guys getting the lecture? Can I get some answers? Okay. 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 So please just have a little bit more patience. If you can have a little more patience, then we only have 2 more pages, and then after that we can finish neurology. Okay. How great is that? That would be absolutely amazing. Okay. So that's what we will do. Okay. So have you guys understood the lecture all till now? Oh, great. Okay. Okay, great. So what we would do is we will instead of trying to learn these things first, let's finish the glaucoma drugs because we have already learned about them, and okay, they can be finished very easily. Okay, let's learn about the glaucoma drugs very quickly and we can be done with this. Okay, so first of all, which I want to know is, okay, what are the drugs that are used to decrease the production of aqueous humor? I talked about this yesterday. ABC, very good. Very, very good, guys. Okay, so fast answers, please. ABCs are alpha 2 agonists, and then beta blockers and carbonic anhydrase inhibitors. Okay, then what are the drugs that is used to increase the outflow from the trabecular meshwork? Trab the, you guys remember? What was the mnemonic? What was the mnemonic that we use? Trab the mouse. Very good. Trap the mouse. Okay, so M3. M3, okay, M3 are cholinomimetics, okay, and then another one was increase the outflow through the uvoscleral pathway. What was the mnemonic that we used to increase the outflow? That you remember? Okay, go up for UP for UV scleral and prostaglandins. Okay, so can I get some examples on some beta blockers, please? Can I get some examples on the names of some beta blockers that are used for coma? Okay, so we have Malol, okay, and then we have another high yield drug. Okay, another high yield drug that is, it's not atenolol. At atenolol, there's more cardiologic beta blocker. Can we have the name of another glaucoma drug? Have you guys heard of betaxolol? Betaxolol, yes or no? Yes, betaxolol. Okay, so beta blocker, timolol, and betaxolol. Okay, very good. Okay, can I get some names of cholinomimetics? M3, M3, M3 drugs. Does anyone have any idea? Pilocarpine, very good. This is the direct cholinomimetic. Does anyone know the name of an indirect cholinomimetic? Indirect cholinomimetic? Indirect. Not physio, physo. Okay, physostigmine. Very good. Okay, neostigmine, physostigmine. Okay, very good. How about prostaglandin analogs? Does anyone know the name of some prostaglandin analogs? Latanoprost and bimatoprost. Very good. Okay. And can we also use carbonic anhydrase inhibitors? We already said we did. Okay. Carbonic anhydrase inhibitors are used to decrease the production of aqueous humor. What is the name of the carbonic anhydrase? Okay, it's acetazolamide. Very good. Acetazolamide. Okay, so having said that, you guys have said the names of the drugs even before I could say the names. So beta blockers, you have timolol, betaxolol. Alpha 2 agonists are obviously known to us. That is epinephrine, okay, brimonidine. Diuretics, in which carbonic anhydrase are the ones, acetazolamide. Prostaglandins are bimatoprost, bimatoprost, okay, and latanoprost, okay, so latanoprost. And then cholinomimetics are direct and indirect. Indirect, the most important one is pilocarpine, and in indirect, the most important one is physostigmine. Okay, very good. We have also read the mechanisms. We know what the mechanisms are, that these drugs, okay, they all decrease aqueous humor synthesis. They all decrease aqueous humor synthesis. That's easy to understand. Then we said Trap the mouse. Trap the mouse for mechanism is in which increase outflow of aqueous humor via the trabecular meshwork. Okay. Another one was go up. Go up for uvoscleral and prostaglandins. They increase the outflow via the uvoscleral pathway. So we're done with the mechanism. Are you guys okay with this? Okay, have you guys understood that we have already read the mechanism? We have already read the names of the drugs. Yes or no? Have you guys understood? Okay. Okay, good. Okay. Next one. Next one is some notes over here. I mean, some adverse effects. So beta blockers have no adverse effects in the eye. Alpha agonists, okay, we have to be very careful that we do not use alpha agonists or any drug which increases the pupillary diameter or causes pupillary dilatation in closed angle glaucoma or narrow angle glaucoma, because this will only cause further damage to the eye. Okay, because already in narrow angle glaucoma the angle is narrow, so the fluid cannot drain. So we have to use we cannot use pupillary dilatory drugs that can cause more further dilatations. Okay. Next ones are diuretics. They have no adverse effects of the eye. Prostaglandins can cause some amount of iral darkening, but it's not important. Okay. Cholinomimetics are the ones that we have to use in narrow angle glaucoma. Why? Because cholinomimetics can cause constrictions, and these are the ones that are used in closed angle glaucoma. We use pilocarpine in closed angle glaucoma. Okay. Okay. So have we understood the glaucoma drug? Do we have any questions? Do we have any question from the glaucoma drugs? Okay. Okay, good. Good. Next one which we are going to study is neuromuscular blocking drugs. Okay, neuromuscular blocking drugs. Okay. Now, what is the neurotransmitter that is used for? Okay. Do you guys want to take another 5-minute break before we finish the last 2 pages? Because we won't be doing any notes for today either, because we have finished such a big topic. Okay, because I feel like you guys are not responding as much. Okay. Last 5-minute break, yes or no? Okay, so after that last 5 minutes, we can finish the neurology. Okay, so we will only be having these two. We will only have these three things to study. Okay, so we will take a break for 5 minutes. Okay, so are you guys back from the break? 5-minute break. We're done. We're done with the 5-minute break. Are you guys back? Okay, good. Okay. Okay, so you guys are doing a very good job holding on to your patients. Thank you so much for keeping your calm and composure for neuropharmacology, because this is an extremely important, extremely big, and a very high yield topic. And we are very close to finishing it. And I want to thank you guys for keeping your attention to the lecture for today. And each and every one of you are here. You guys did not leave. Thank you so much. Okay, and we are very close to being done. Is everyone ready to finish neuropharmacology? Is everyone ready to finish neuropharmacology right now? Yes or no? You are absolutely welcome. Okay. Okay, epinephrine is not used in closed angle glaucoma. Epinephrine is only used in open angle glaucoma. Okay, open angle glaucoma. Are we clear? Epinephrine can cause decreased aqueous humor production. That's why it's used in open angle glaucoma. It's not used in closed angle glaucoma. Okay, you are absolutely welcome, Dr. Iman, for letting me know that we are trying to make things easy for you and everyone else. So thank you so much. Okay, having said that, let's start with the last group of drugs and we will finish it very quickly. And this is very easy. All you have to do is put a little bit more attention and then we will be done. My first question for you all is, which neurotransmitter is used in the synaptic cleft to induce an action potential in the post-synaptic neurotransmitter? Very good, acetylcholine. So if we have increased amount of muscle, do we want to increase acetylcholine or do we want to decrease acetylcholine? What's our answer? If we have increased muscle contractions or muscle spasm, do we want to increase acetylcholine or decrease acetylcholine? Decrease acetylcholine. Very good. Our answer is we want to decrease the acetylcholine. Okay, and how do we decrease acetylcholine? That's the whole goal about studying neuromuscular blocking drugs. Okay, so first of all, the first approach that we can take is using succinylcholine. First of all, this is what you have to understand about succinylcholine. Okay, what succinylcholine does is, okay, we don't have a space over here. Give me 1 second. Okay, let me just get another blank page. Okay, so first of all, what succinylcholine does is, let's say that this is an acetylcholine receptor, okay, and this is succinylcholine, and succinylcholine is a very strong ACH, acetylcholine agonist, okay, acetylcholine agonist, okay. So what this does is, succinylcholine, when it comes, it causes excessive depolarization. When you have an excessive depolarization of a receptor, does the receptor get worn out, tired, and stop working? Yes or no? Does it cause downregulation of the receptor? Yes. As a result, if succinylcholine causes excessive depolarization, will there be downregulation of the receptor? Yes or no? Fast answers, please. Yes, there is down regulations of the receptor. If in the future acetylcholine wants to come and bind to the receptor, will it cause more acetylcholine contractions or less acetylcholine contractions? Is no receptor. Less. Very good. Thank you so much. So if there is no receptor because it's been worn out from succinylcholine, because succinylcholine has worked the receptor so much that the receptor has worn out, gotten tired, and downregulated itself. So next time when acetylcholine comes to bind to the receptor, they will find that the receptors, oh, where are the receptors? The receptors are not there. Okay, so acetylcholine will not work. Okay, so that's what it is. So that is the mechanism of depolarizing neuromuscular blocking drugs. And the only drug that is used is succinylcholine, which is a strong receptor agonist, which causes sustained depolarization and prevents muscular contraction. Okay, so that's that. And this happens in 2 phases, that is in phase 1 and phase 2. In phase 1, this causes prolonged depolarization. And in phase 2, due to downregulation, there is repolarization, but there is no blockage. Okay, so the receptors are not blocked, but the receptors are not there. Okay. And in the phase 1, it cannot be prevented by cholinesterase inhibitors, meaning that we cannot give cholinesterase inhibitors to block the acetylcholine. But if you want to reverse the effect of succinylcholine, this can only be done after the receptors are down regulated. So this phase could be reversed with cholinesterase inhibitors, meaning that if right now that the receptors are down regulated, but acetylcholine, let's say that this is the synaptic cleft. Now the receptors are over here, okay, down-regulated, and acetylcholine comes, okay, and acetylcholine sees that, okay, where is my receptor? My receptor is not there. So if the acetylcholine leaves, then the muscles will still stay relaxed, okay? But if we can give acetylcholine esterase inhibitors, okay, which will prevent the breakdown of acetylcholine. So the acetylcholine, what will happen is the acetylcholine will stay here for a long period of time in order for eventually the receptor to come out at one point, and then acetylcholine will bind, and then this will reverse the whole this will reverse the muscle relaxation, okay? Have we understood the reversion? Have we understood the reversion? So in which phase can we use? Phase 1 or phase 2? The cholinesterase inhibitors. In which phase can we use? Phase 1 or phase 2? We can use them in phase 2. So we can use them in phase 2. Very good. Okay, next one. Okay, next one is what I want to talk about is okay, next one, what I want to talk about is, first of all, I want to talk about that one drug, okay, that we use for malignant hyperthermia. Well, what is that one drug that we use to treat malignant hyperthermia? Can I get some fast answers, please? Dantrolene, okay, dantrolene. And does dantrolene work by preventing the release of calcium from sarcoplasmic reticulum? Yes or no? Does dantrolene work by preventing the release of calcium from? Okay, good. Okay, good. Okay. And another one is okay. So have you guys ever received, okay, so do we have any students over here who is a big fan of cycling? Does anyone love cycling? Does anyone love cycling? Who loves cycling over here? Okay, cycling, okay, it's a very good exercise. Do you have any students over here who goes to spin classes? Good, very good. Okay, so spin classes. So in spin classes, what we do is we do cycles. If you do an excess amount of cycling, do you get muscular contractions? Yes or no? Yes or no? Okay. Yes, if you do excess amount of cycling, you can get muscle spasm. And we have this one drug. Okay, we have this one drug which can help you prevent that. And that drug is known as cyclobenzaprine. Okay, what is the name of the drug which can prevent your muscular contractions when cycling, for example? The name of the drug is cyclobenzaprine. So what does cyclobenzaprine do? Cyclobenzaprine is used for muscle spasm. Okay, and the C in cyclobenzaprine can help you remember the cyclobenzaprine act in CNS or PNS. CNS or PNS? Fast answers, please. CNS or PNS? C for CNS. Easy. Okay? So first of all, if you get muscle spasm, we use a drug. The name of this drug is cyclobenzaprine. And where does cyclobenzaprine work? In the CNS or the PNS? It works in the central nervous system. So it's a centrally acting drug. Cyclobenzaprine for muscular contraction during cycling. We use cyclobenzaprine, for example, and cyclobenzaprine is a CNS acting or centrally acting drug. Okay, and another one is okay. So have you guys ever had back spasm of the back muscle spasm after sitting in your chair for a long period of time? When you guys get up from the chair, don't you guys get back spasm where your lower back kind of hurts? Okay, so if I tell you that always, exactly, so you know exactly what we are talking about. So if I tell you that we have a drug, okay, which works on your back, okay, that drug is called baclofen. Okay, that drug is called baclofen. Baclofen acts on the back, meaning that it acts on the spinal cord. Okay, and baclofen is almost like gabapentin, meaning that baclofen is a GABA Okay, okay. Baclofen is a GABA receptor agonist. Okay, and where does it work? In the brain or in the spinal cord? I just mentioned where it works in the brain or in the spinal cord. It works in the back. So what does the back have? The back has the spinal cord. So baclofen works in the spinal cord. Baclofen works in the spinal cord. Okay. 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 So once again, name of the drug for malignant hyperthermia. What is the name of the drug for malignant hyperthermia? Daleen. What is the name of the drug that can cause muscle spasm and during cycling, and we use it for centrally acting muscle relaxant, central acting muscle relaxant, cyclopentazine. What is the name of the drug that works in the back of in the spinal cord for back spasm? Say for example, baclofen. Very good, very good. Okay, have you guys heard about my friend? Have you guys heard about my friend Tiza? Yes or no? Okay, obviously the answer should be no because you guys have not heard about her. Have you guys heard about my friend Tiza? No? Yes or no? Have I talked about her before? No. Okay, I have not talked about her before. Okay, so my friend Tiza. Okay, Tiza is my friend who has MS. Okay, Tiza is my friend who has MS. And unfortunately, this unfortunate friend of mine has MS. She has also been recently diagnosed with ALS. And growing up, she always had CP. CP meaning she always had cerebral palsy. So how many diseases did my friend Tiza have? How many diseases did my friend Tiza have? Tiza is a friend called Tiza who is unfortunate because she has 3 diseases. Okay, so Tiza. Okay. ALS, amyotrophic lateral sclerosis. Okay. So my friend Teresa, okay, Teresa or Tiza, okay, Tiza is my friend who had MS, who had ALS, and growing up she also had CP, CP meaning cerebral palsy, and the drugs that is used to treat ALS, ALS, MS, CP, and muscle spasticity is tizanidine, okay. Tizanidine, okay, tizanidine. And this is my friend Tiza who had ALS, MS, and CP. Okay, so is that going to help you guys? Is that going to help you guys remember that tizanidine is used to treat ALS, MS, and CP and muscle spasticity. Okay, so once again, last and foremost, what is the drug that is used to treat malignant hyperthermia? I know you guys are annoyed by me asking the same things over and over again. Dantrine. Very good. What is the name of the drug that that is a central acting muscle receptor? Central acting muscle receptor. I mean muscle relaxer. Okay. Cyclobenzapine. Very good. What is the name of acts on the spinal cord? That acts on the back of the spinal cord. Okay. What is the name of the drug? Okay, that is used to treat MS, CP, and ALS. All the things which my friend Tia has. Tizanidine. Tizanidine. Okay, so guys have finished your spasmodics or antispasmodics. Okay, do we have any questions? Do we have any questions? CP is cerebral palsy. CP is cerebral palsy. Okay, do we have any questions regarding on how to memorize these drugs? Because we have just memorized them. I asked you and you gave me answers. Okay, okay, was that helpful? Was that helpful? Yes or no? Oh, good. Very good. And we are very close. Next one is opioid analgesics. And the best part about opioid analgesics are we are very well aware and well acquainted with opioid analgesics. Can you guys give me 1 second, please? Okay, okay, my apologies. Okay, that was a call from the hospital. Okay, so that's that. Okay, so we have done finish. We are done finishing antispasmodics. I mean antispasmodics and spasmolytics. Okay, next one. Okay, so are we ready to start opioid analgesics? Are we ready to start opioid analgesic? Yes or no? Okay. So we all know what opioid analgesics are. Okay, we know that opioids are, let's say, morphine, heroin, meperidine, right? These are the ones. Okay, so what are the receptors for opioid uh, analgesics, and what are the opioid receptors? We have, okay, how many receptors do we have? We have mu, we have kappa, and then we have delta. Okay, we have mu, kappa, delta. And the reason why I like to use mu, kappa, delta, okay, the reason why I like to use mu, kappa, delta is mu, kappa, and delta. Okay, mu, kappa, and I'm sorry. Okay, one second. The way I would like to use it is mu, delta, and kappa. My apologies. Okay, mu, delta, and kappa. And the reason I want to, it should be in this order is because mu is used for beta endorphins. Mu is used for beta endorphins. Delta is used for enkephalins. And kappa is used for dynorphins. Kappa is used for dynorphins. Okay, so mu, kappa, and delta. So mu, kappa, and delta. That's what it's used for. So mu, kappa, and delta is used for beta endorphin, enkephalin, and dynorphin. So the word is bed, B-E-D, bed for mu, kappa, and delta. So mu is used for beta endorphin, delta for enkephalin, and kappa for dynorphin. Are we clear? Are we clear? Yes or no? Okay. And the way that these work is, okay, the way these work is these receptors, the opioid receptor, let's say that this is the opioid receptor over here. Once the opioid comes and it comes to the opioid receptor, what this does is the opioid receptor, this closes the calcium channel close, and potassium channels open. Potassium channels open. So this opioid receptors, if they ask you what is the mechanism of action of an opioid, you will tell them that opioids bind to the opioid receptors. After that, they close the presynaptic, okay, they close the presynaptic calcium channel and open. So once again, okay, you know what, let me just get a fresh page. Let me just get a fresh page, okay, because the mechanism of action of opioid is very high yield, okay. Okay, so this is presynaptic, okay, this is presynaptic, and this is postsynaptic. Okay, okay. And what happens is opioid receptors, okay, mu, kappa, or delta, depending on which one. So beta endorphin, enkephalin, or dynorphin. What they do is they come and then they bind to the presynaptic receptor over here, and they close the voltage gated calcium channel. They close the calcium channel, and the ones which come to the presynaptic ones. Okay, if you close the calcium channel, can there be more release of neurotransmitter or less release of neurotransmitter? Presynaptic. If you close the presynaptic calcium channel, very good answer. If you close the presynaptic channel, there will be less release of neurotransmitters. And if you close, if you open the postsynaptic potassium channel, if you open the postsynaptic potassium channel, will the postsynaptic neuron be hyperpolarized or depolarized? Hyperpolarized or depolarized, please? Hyperpolarized, very good. This potassium will leave the cell and the cells will get more negative. So as a result, what's happening? There is decrease of neurotransmitter, there is decrease of neurotransmitter, and there is increased negativity, right? There's increased negativity in the postsynaptic membrane. Okay, so as a result, will there be more impulse transmission or low impulse transmission? Fast answers, please. More impulse or less impulse? Very good.
less impulse transmission. Okay, so that is the mechanism of action. And now let's talk about the agonists. Okay, let's talk about the full agonists. Full agonists are morphine, heroin, meperidine, methadone. Okay, we know the names of these ones, codeine and fentanyls. Okay, next one is partial agonists. Partial agonists are that they partially activate the receptors and they partially do not. Okay, so partial agonists are buprenorphine. Buprenorphine. Okay, you just have, this is the hard part. You have to remember the names. That's what it is. Okay, and the most important one is you have to remember the antagonists, the names of the antagonists. So what are the antagonists that are used? The antagonists are naloxone and naltrexone. Naloxone and naltrexone. Okay, naloxones and naltrexones. Okay, so have we understood the names of the drugs? Have we understood the names of the, I'm pretty sure you guys know all the names. Okay, this is nothing new to you guys. Okay, and antagonists, opioid antagonists are naloxone, naltrexone, and methyl naltrexone. I'm pretty sure you guys knew this. Yes or no? Yes or no? Get some answers, please. Yes or no? Yes. The answer is yes. Very good. Okay, where is opioid most commonly used? For which purpose? What is the purpose of use of opioid? Pain. Very good. So post-operatively, if there is operative pain, we give the patient morphine to decrease pain. Okay. Is there an opioid that we can use to treat diarrhea? Is there an opioid that we can use to treat diarrhea? Yes. What name that? Loperamide. Very good. Loperamide is the opioid that we can use to treat dry cough. Cough. Yes. What is the name of that opioid? Codeine. Very good. Okay, codeine. Okay, a lot of people abuse that. Okay, a lot of people abuse codeine. So that's that. Okay, a lot of people abuse codeine. Okay, next one is very good. So we are done with the clinical uses. Okay, and can we use long-acting opioids for previous addicts? Yes or no? Can we use long-acting opioids for previous addicts? Yes, we can. We can use acting opioids. Okay, we can use long-acting opioids because they will not have the signs symptoms of an addict, and this will decrease the withdrawal. Okay, so if anyone has opioid withdrawal, which drug do we use? The drug we use is methadone. Okay, anyone has toxicity to opioid, which drug do we use? Fast answers, please. Which drug do we use? If anyone has toxicity to opioid, naloxone or naloxone. Okay, very good. Okay. Along with this, they can also cause nausea, vomiting. Okay, respiratory depression. This is very common. They can also cause constipation because they decrease the movement of bowel. Okay, and they can also cause meiosis. Okay, so how will you receive patients about opioid indications? Okay, hear me out. This is an extremely important question. So if you have to receive questions about opioid intoxications, you will have patients who will come to you with pupillary constriction, then confusion, then the patients will have low respiratory rate. Okay, then the patients will have constipation. Say constipation. Did I say constipation? Yes or no? Okay, let me write it down. Okay, signs and opioid intoxication: decreased respiratory rate. Okay, confusion. Okay, then constipation. Then okay. So these are some of the most important sign symptoms of opioid overdose. Okay, if you have to have a patient who comes with these type of conditions. Okay, what is the drug once again that you will prescribe? Fast answers, please. Naloxone. Okay. And another high yield question is regarding tolerance. Okay, you will receive a question regarding this in your UWorld. Okay, which symptom
does the patient not get tolerated to when using opioids? You will receive this question. In U world, okay, what are the symptoms that the patients will not get tolerated when using opioids? And the two symptoms are meiosis and constipation. Have you guys received this question in U world yet? Have you guys received it in U world yet? Yes, very good. Okay, very good. So you guys know exactly what I'm talking about. Okay, so that's what it is. Okay, good. Okay, good. Okay, last time we discussed it. Okay, good. We discussed it last time. Okay. Okay, once again. Okay, good. So there are two more drugs that I want to talk about. Okay, there are two more drugs that I want to talk about. That is pentazocine and butorphanol. Okay, pentazocine and butorphanol. Okay, and we are very close to the end. Okay, so pentazocine. Okay, first of all, let's go back to the lecture. Pentazocine and butorphanol. What is pentazocine? Pentazocine is basically a kappa. Okay, we have the mu delta kappa. So pentazocine is a kappa receptor agonist and a mu receptor antagonist. Okay, and the most important thing is it can cause opioid withdrawal. Okay, so if you have a question about if pentazocine being a partial agonist, okay, is pentazocine, okay, it's also a type of partial agonist because it will bind with the kappa, but it will not bind with the mu. So it can cause it can cause withdrawals, opioid withdrawals, okay, who are taking full opioid agonist. How will you receive questions about this? You will receive questions about this, that you will have a patient who has come to you in the hospital, and the patient all of a sudden has diarrhea, the patient has fever, the patient has mydriasis or pupillary dilatation, and the patient is acting unnatural, the patient is agitated. These are all the signs, symptoms of opioid withdrawal. And if they ask you which drug was administered to cause these signs, symptoms, first of all, you have to diagnose that this patient has opioid withdrawal, and then you have to look out for this drug in your ancestry. That this drug is pentazocine. Okay, pentazocine. Okay. Are we clear about the question regarding pentazocine? Yes or no? Are we clear regarding the question of pentazocine? Not clear. Okay. First of all, what are the signs, symptoms of opioid withdrawal? Opioid withdrawal: diarrhea, mydriasis, okay, sweating, confusion, okay, confusion, then agitation, fever, okay. So these are the signs, symptoms of opioid withdrawals for a long time. For a long time opioid addict, for example, a heroin addict. Okay, if they stop taking heroin, then they will have withdrawals like this. Okay, and if any of these patients are admitted to the hospital, and if they tell you that you have a patient who has these signs, symptoms, what is your diagnosis? Can I get some fast answers, please? What is your diagnosis? I just said the name of the diagnosis. What is your diagnosis? If you have a patient with the signs, symptoms, opioid withdrawal. Very good. And which opioid drug can cause these signs, symptoms? Which opioid drug can cause pentazocine? Very good. That's my question. Okay, that's my question, and that's my answer. Okay. Okay. Good. Next one is butorphanol. Okay, butorphanol. Butorphanol is a kappa receptor agonist and a mu opioid receptor partial agonist. Okay, so all the partial agonists are very dangerous because partial agonists have to be closely monitored because partial agonists can cause opioid withdrawals in a previous opioid addict. Okay, but the thing is, butorphanol, it is used for severe pain, and pentazocine is used for moderate pain. Okay, but we have to be careful when we are using them. Why? Because they can cause opioid withdrawals. There's nothing more important that you have to know from over here. Okay, nothing more important. And we have come to the last drug. Okay, I am so excited that we have come to the last drug. I'm so excited that we have finished neurology. Okay, extremely happy over here right now. Okay, so are you guys ready to finish the neurology with the last drug, that is tramadol? Yes. Yes. Oh, we did not discuss non-depolarizing drugs. Oh man. Really? Okay, wait 1 second. Yes, you're right. You are right. We did not discuss them. We just jumped to spasmodics.
Okay, good. Who's the doctor who made me real? Dr. Iman. Okay, Dr. Iman, thank you so much for remembering that. Okay, very good. Okay, non-depolarizing agents. These are very easy to understand. What are non-depolarizing agents? Example, you have acetylcholine receptors. Okay, these simply come and block the acetylcholine receptors. And acetylcholine, can they work if acetylcholine receptor is blocked? Yes or no? No. Okay, so they are acetylcholine antagonists, basically. Okay, so atricurium, cystocurium, they are competitive acetylcholine antagonists. As simple as that. And once again, if we have to reverse the antagonist action, do we want more acetylcholine in the synapse or less acetylcholine in the synapse if we want to reverse it? More acetylcholine. If we want more acetylcholine in the synapse, do we want to inhibit acetylcholinesterase? Yes or no? Yes. Okay, good. So we want to inhibit acetylcholinesterase because acetylcholinesterase inhibition will result in more acetylcholine, and acetylcholine can eventually cause the reversion of the sign symptoms. Are we clear about non-depolarizing agents? Names are easy. The names are all curiums, atricurium, cystocurium, pancurium, okay, rocurium. Okay, are we clear? Okay. Okay, good. Now, are we ready to finish neuropharmacology? Right, right. Good. We have to remind you about one table which we have escaped plus one picture. Very good. Okay, but are we ready to finish neuropharmacology or not? Tramadol, tramadol. Okay, tramadol. Okay, so the last drug that we have to finish is tramadol. Okay, good. Next one. So the last drug which we will finish is tramadol. Okay, so tramadol is, first of all, tramadol, it's a very weak opioid agonist. Okay, first of all, it's a very weak opioid agonist, but what this does is this inhibits the reuptake of epinephrine, norepinephrine, and serotonin. Okay, so if we have the release of if for 1 second, for example, let's say that this is the presynaptic, okay, and this is the postsynaptic, okay, and these tramadols, what they do is they are SNRIs, more or less. They prevent the reuptake of norepinephrine and serotonin. If you have more serotonin, do you have more pain or less pain? More serotonin, pain or more pain? Very good. Okay. So you prevent the uptake of serotonin and norepinephrine. What this will do is this will decrease your pain. Okay, and they're used for chronic pains. They are very similar to opioids, but they are opioids. But the thing is, this is important. This is a high yield UL question. This is a high yield UL question that they decrease the seizure threshold level. They decrease the seizure threshold level. Okay, and they can cause serotonin syndrome. So people who are taking, patients who are taking tramadol, okay, patients who are taking tramadol, they can have seizures. That is very important. Okay, these are there. Okay, that's that. So, and it can also cause serotonin syndrome. Okay, and this is just a mnemonic they have said. Serotonin and norepinephrine inhibitors used for stubborn pain can lower seizure threshold level and can cause serotonin syndrome. So if you have to remember two things about tramadol, first of all, it's a serotonin and norepinephrine reuptake inhibitor. And second of all, it can cause seizure and serotonin syndrome. Okay. Okay. Are we clear about tramadol? Okay. So with that being said, we have successfully finished neuropharmacology. We have successfully finished neuropharmacology. Okay. Okay. Now, although we are done with neurology, there is still one thing which I wanted to discuss with you guys. I'm not sure if we'll get a lot of time discussing that today. Is the high yield CT scan and MRI images? The high yield CT scan and MRI images. So, is it possible that we keep the CT scan and MRI images for next week? In that way, I get some time to, okay, and along with the CT scan and MRI images, I will discuss the table about the neurotransmitters which are increased or decreased, okay, because I believe we are very exhausted today, okay, and I'm not gonna lie, even I'm a bit exhausted from all this drugs, okay, because drugs are very exhausting. There are so many things that you have to learn about the drugs. mechanism of action, adverse effects, where to use them, and then what type of questions are coming from the drugs. But hopefully, I tried my best. I tried my best to make you guys understand the drugs in the easiest way possible. Okay. If you guys have any more questions, please let me know. But have you guys understood the lecture for today? Have you guys understood the lecture for today? Okay. Could I make the lecture a little bit easy for all of you to remember each and every drug? Okay. Okay. So I'm glad you guys understood the whole thing. Okay. Now you guys receive questions from neuropharmacology. Would you guys be confident in answering the questions, yes or no, especially the seizure drugs? Okay, very good. Okay. So with that being said, since this is a Friday and this is the last lecture of the week, I do not want to force you guys into doing any more questions or any more UWorld notes. Okay. Friday, we should take things a bit slower, and we did not. Okay. We already studied an exception amount of first aid today. Okay. We studied neuropharmacology, which is a high yield subject. And not only did we read through first aid, we memorized each and every details. Am I correct? Did we or did we not memorize, review, and recall each and every drug? Yes or no? Okay. So what is your duty after this? Your duty is to solve the question. Your duty is after this, you have to solve the questions, or else you forget the knowledge and you cannot apply the knowledge. If you don't apply the knowledge, you will forget the knowledge very fast. Very fast. You will forget about the neuropharmacology very fast. Okay. So you have to apply the knowledge as soon as possible. Okay. As soon as possible. So with that being said, I want to thank you guys so much for keeping your calm and composure during this whole 2 weeks of neurology. Okay, hope I could help you guys out. And with that being said, I would like to end today's lecture. Okay, and once again, please try to complete the transactions for next week by Monday. Okay, we will send you guys the requests, and we appreciate you guys for completing the transactions on time, because this really helps us focus on how many students we are dealing with, what we have to study, what lesson schedule we will need. And from next week, we will get you your own lesson schedules. Okay, first of all, what are the things that you can look forward to for next week? The thing that you can look forward to for next week is your subscription to Dr. Najib, in which you guys will have your subscription to Dr. Najib. Obviously, if you start the lecture with us from next week, we will provide you with the email ID and the password. And then each and every week, we will choose 3 to 4 doctors who can use Dr. Najib and 3 to 4 doctors who can use physio. And we will make a routine. And from the next week, things will get changed. And then the students who used physio will use Dr. Najib, and the students who has used Dr. Najib will use physio. Okay, so this is how we will use the Dr. Najib and physio resources. Okay, for everyone, so that you guys can try to watch the videos and try to polish your knowledge. Okay, but in order for you guys to do that, okay, I would expect each and every one of you to be present on the next week's lecture, because we have a very important topic for next week. Okay, our important topic for next week is psychiatry, and psychiatry is extremely important, and this is one thing which needs a lot of discussion. And if you guys know anything about us, then you know that we like to incorporate stories. Okay, and there will be a lot of stories and a lot of fun with psychiatry. Okay, this is a very fun subject. So that's that. Okay, psychiatry, how many days? We are still not sure. Okay, we will give you guys the lesson schedule on Monday or Tuesday. Okay, okay, lecture 19. I will not forget this. Okay, so I will send you guys. We will send you guys the requests on PayPal, and please try to complete it by Monday. Hope you guys have a great weekend. Okay, I hope you guys have a really good weekend. You have worked so hard throughout the whole week. Okay, you guys have finished neurology and this set. Okay, so try to have a little bit of fun during the weekend. Try to get your mind loose, because you guys will need to get rejuvenated for your next week's lectures. Okay, next week is very important. So that's that. Having said that, okay, this is me signing off. Okay. Hope you guys have a great day. Let me know if there's anything you guys want me to answer. Send me an email. Oh, and last and not the least, if possible, please can you guys give us some ratings or reviews on our page, because we are in need of your help. Okay. If you guys think we are doing a good job, you can give us a review. If you guys think we're not doing a good job, you guys can still give us a feedback on how to improve ourselves, because your feedbacks are extremely valuable and we need your feedbacks to better ourselves or to motivate ourselves. Okay, so please, 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 we want you guys to give some reviews or some feedback so that we know that we are doing a good job or not. Okay, being said, I will take my leave right now. Hope you guys have a great day and see you all on Monday. Okay, bye-bye.